Ladies and gentlemen, we welcome you to the GUJCON-2022 themed on the occupational health challenges and strategies. On behalf of IOH Vadodara, we are pleased to have you present today. Myself, Dr. Sujata Rane, and scientific committee look forward to give you enriching experience of the content filled with knowledge, wisdom, and experience, and also technology. We have tried to include the sessions which will give you 360-degree view of what is actually needed and makes an occupational health professionals a business enabler in the organization. My colleague Dr. Amar Rathi will be the scientific manager for the first session, and Dr. Kalpita will be handling the second session. Now over to you, Dr. Amar Rathi.
Good morning, everybody. Welcome to day 1, scientific session 1. This session is this session has 4 speakers. I now welcome the chair, Dr. Jayant Patel, present IAOH Surat branch president, and Dr. Jagdish Kamath, current vice president IAOH Vadodara chapter, to take over the chair. Now requesting the chair to introduce the speakers. There are 4 speakers. Requesting the chair to conclude this session by 12:30 p.m.
Good morning, everyone. I welcome you all on behalf of IOH Vadodara. Today, our first speaker, the opening batsman, is Mr. Ujjwal Shah. He is a Bachelor of Engineering. He has done PDIS, and he is also Industrial Environment Management degree holder. He is also Industrial Hygienist, and he is associated with ProSep Global EHS. He is having more than 18 years of experience, and he is fire safety specialist empaneled with Gujarat State Fire Panel Services, IH from BOHS UK. He is also lead auditor for ISO 14001, ISO 45001, and trainer from Lee H. Harrison. He has worked with Apollo Tires, ABB, Siemens, Welspun, Raychem, and Sustainable EHS LLP. He currently owns a firm, ProSep Global EHS. I welcome Mr. Ujjwal Shah, and he will deliver talk on emergency preparedness in industry. It's a very vital topic, and everyone is eager to know about this, sir.
કેમ છો બધા? થોડું લાઉડ થઈ ગયું. કેમ છો બધા? ચા નથી પીધી? So, thank you very much. અને બધા રેડી છો? રેડી છો ને ખરેખર? પણ શેના માટે? સાંભળવા માટે તો ઠીક છે, પણ ઇમરજન્સી એના માટે રેડી છો? સો લેટ અસ હોપ there is no emergency in today's time, ખાસ કરીને આપણા આ ટેન્યોર દરમિયાન. I'll be speaking about emergency preparedness in industry, and will be not covering in detail legal aspects and technological aspects which you all might be knowing, but I will be more focusing upon framework and what we should take care while we are planning for an emergency. So, to start with, there is a series of incidents which we are coming across, and we are seeing this day in, day out. Two instrumental incidents which we can say, Bhopal tragedy and recent one, or in 2009 we had Jaipur IOCL fire. There are so many major incidents which has happened thereafter also. Can few of you, if remember, would like to quote any incident, recent one? Anyone? Okay. Thank you. Yes. So, within last 2 years, we have Vizag, Yashasvi Rasayan. If we talk about within Gujarat, we had GFL, then Canton Laboratories, Deepak Nitrite, recent one. So, we are seeing this day in, day out. What has changed? What has changed or triggered our legislation post-Bhopal? So, there are series of statutes which has been actually amended. You can see Factory Act, specifically Chapter 4A was added. Hazardous processes has been added in respective sections. An on-site emergency plan, we had already 33 annexures, we all know that. Environment Protection Act also came into force post-Bhopal tragedy. MHISC rules, and so on. Recent one, Gujarat State Fire Prevention and Life Safety Measures Act, and recently amended rules 2021. So all we can say, post-Bhopal tragedy, we had even looked at our legislation, had amended it. What is the broader objective we can say for emergency preparedness? To control and contain emergency, possible disaster if we can contain and eliminate of occurrence, minimize the effect of emergency on person or persons, property and environment, to save lives and injuries, to not only human, we need to think comprehensively about all creatures, to prevent or reduce property losses, to provide quick resumption of normal situation or operation. So as we all might be aware of, you might have prepared your disaster management plan, you might have prepared your on-site emergency plan. There are 3 levels of emergency we consider. Level 1, which can be specific to your any building or plant area. You may consider it as a small spill, fire, or failure of any small equipment. Level 2 could be your major but controllable within factory premises. Still it is on-site emergency. It may be due to big fire in factory premise, medium scale explosion. And level 3 could be your major in and around factory premise. It may occur outside also, which can impact you, or it may occur inside your premises and which may impact the neighbor factories or neighborhood. As we know, types, natural and man-made, there are number of things which can be considered. So, planning is very crucial for any kind of emergency preparedness. If it is said that planning is prevention and preparedness, a comprehensive emergency response would cover not only site incident, but all off-site incident. If we take an example that there is a company who is actually located, is an engineering company, might be located near National Highway, but there is a tanker who is having toxic gas and has been toppled down and there is a toxic gas release. So there can be an off-site emergency to that company who is not even falling into MH category or even not having that kind of issue. So we need to be prepared for worst. The emergency action should address emergencies that the employer may reasonably expect at the workplace. So we should be very much concerned about our own premises, what we are doing, what can go wrong, and nearby what kind of activities are happening. Policies and procedure needs to be developed wherein we need to consider all kind of hazards. It may be safety, health, which may be acute or chronic, fire and explosion. We also need to consider environmental damage, which can be immediate or long term. We need to consider existing standards and legal requirements, knowledge of the company operation. This is very mandatory when we consider of any kind of a preparation. We need to consider the operation, which is we say process, and people, how they react. Information on external sources, like where is the nearest fire brigade, where is the nearest medical service or trauma center, we need to be aware about it. So how this emergency management approach goes? If suppose there is an incident, normally we are prepared, but between preparedness and response, we find an incident. So while we are preparing for the same, we need to very well work upon prevention and mitigation. How we can do that? We can actually continuously see our on-site emergency preparedness, considering hazard identification, consider all hazards, risk analysis, critically analyze the risk matrix, evaluation, comprehensively evaluate it, research. There is an AI and human-machine interface. There are new technologies which are there. Work for human error prevention. Most of the accidents or incidents which we see has human error in its back. Education, there should be a continuous exercise to ensure capacity building amongst all stakeholders. At the preparedness phase, we should consist activities to be carried out in advance before an emergency strikes. Like sir has mentioned that if there is a practice, we can play better. So here, if we have practiced our emergency well, we have considered our scenarios and practiced it well, then we can cater any kind of emergency, whether it can be natural or man-made. Hazard and risk analysis, relevant training, drills, exercise, this can help. At the response phase, what we need to consider is how we can have immediate response to emergency. We may have emergency response team at our place, which can help in minimizing the effect. It is aimed to containing the disaster so as to minimize loss of life and destructive to property. So one may go for a total loss prevention approach. It includes measures such as notification of emergency, identifying how it is occurring, implementation of emergency plans, activation of emergency control center, mobilization of resources, and so on. At recovery phase, what we can do? We can ensure that after an emergency, how people will return to systems and how our operation will resume. We can check physical restoration and reconstruction, cleaning up contaminated areas, salvaging operation, eliminating and or reducing known hazards. There may be a potential hazard which may still be there post-event, which we also need to consider that. Restoring business as a normal business, we do. So, need of an hour is to go for a pragmatic approach. Natural events, accident, man-made disasters, technical breakdowns, rogue employees, external threats are the potential perils. Watch them. Be vigilant about it. The personnel working closest to its operation are the best equipped to detect risk, reducing solutions. Involve them. So, as we see in ISO 45001, consultation and participation, we need to involve people while we are actually ensuring our controls To identify potential crisis, put yourself in the role of a saboteur. So we need to put ourselves into a different hat, and then we need to see what can go wrong. So that can be mind-boggling. Some risks are much easier and cheaper to neutralize than others. Identify and adopt some minor things which may be, you can say, you can consider and control at that point itself. Quantify the risk in terms of potential risk, then probability of occurrence, apply them. We need to apply all controls what we have, which is practically possible. Take a holistic approach in addressing the given situation. Don't comply with fear, comply with grace. So many of industries, or normally what we do, we comply because we have fear of imprisonment, fines, suspension of license to operate, bad publicity, brand image, spoiling, strained employee relations, IR issues. So we may be having fear of this, and this is why most of the companies are following the rules, or rather they are forced to have emergency preparedness. But we need to take it as a grace, compliance with grace. How we can do it? Consider that there can be a human sufferings within premises or outside premises. Even we can be part of, or we can be a victim out of it. There can be a disaster. There can be degradation of quality of life. We have seen that post-Bhopal disaster and many more such disasters, there has been degradation of quality of life. And environment damage. Significant environment damage incident can have. So what are the steps for emergency response and planning? See critically what laws applies to you. Do not just copy-paste on-site emergency plan from one to another. That is what we need to see, what applies to us, that we need to consider. With respect to fire zone, occupancy which you have, and fire hazard. Review any existing system and records with respect to building, evacuation routes, role of key personnel, and so on. Whenever you are having walkthrough, just see that any hazard is there, you just arrest it there and there itself. What can be the step one? Form an emergency response team, which you all might have done. You can just ensure key personnel roles are very well known to them. They have practiced it, and it is very well defined and practiced. You may identify people who are emergency response team members so that they can be identified during the emergency. This is a basic work. Then develop and update, implement emergency response plan. Who has to do what? That we need to definitely consider and develop it. And majorly, whenever there is a change in layout, there is a change in product, you need to consider an amendment and communicate. You can take 6M approach while there is a change. You can check whether there is a man change, machine change, material change, milieu, which is work environment, method and measurement. If there is any change with respect to this, please evaluate the impact. Train all staff. Normally it is said that 10% of your staff needs to be trained for emergency. But here we need to see that emergency preparedness, we need to train all. Whenever new equipments, layout, procedures, exercise is done, please involve key personnel and take consideration of emergency response. Drill should be held random. What is statute is saying? Once in 6 months. But it is ideal that we consider all scenarios and practice at least once a year, all scenarios. You may be having tabletop exercise, you may be having partial evacuation, full evacuation, with medical emergency, without medical emergency. You may involve outside observers as well. Step 4 is evaluate and modify plan. Whenever there is any incident, whenever there is a review, any organizational change, you need to evaluate and modify your ERP. Important elements to consider. Then goal is to evacuate people and move resources. Designation of refuge area. People should know their assembly points and nearest route, how to reach. But many of the time what we find is they are blocked. maps indicating where you are and north direction, and there should be, you can have it photoluminescent. Employees should know where they need to go and how they will be informed. The goal is to evacuate people. Okay, so now what we can conclude out of it is to carry out mock exercise and rehearsals of the on-site plant to ensure that it is an efficient. Test and response is recorded. What went right, what went wrong needs to be recorded with all details like evacuation time and everything. Interaction and coordination of operators, coordination between various departments and function. If there is a gap in between, you cannot fight with any kind of emergency. So you need to bridge those gaps. To evaluate the effectiveness and adequacy of equipment, to gain experience and confidence to implement the plan. So once you practice more and more, you will have a confidence that there can be any emergency, we are prepared. Finalized or updated ERP should be given to all stakeholders for implementation and rehearsal of preparedness. So at last, I want to sum up with few thoughts which I thought of sharing with you. If we have not planned for prevention of an emergency, then we have already planned for one to occur, right? Risk to people, property and environment can be significantly reduced if we are better prepared for an emergency. Don't ignore even a smaller near miss or an undesired event. It can be next disaster. So see if it is there and develop more and more eyes. One safety officer cannot reach to the last. But you develop more and more eyes to see this, then definitely you can identify such a small event and you can cater. Good emergency plan doesn't prevent catastrophe, but drills does. Don't keep your on-site emergency plan on your bookshelves. Keep it is in practice. Try as much as possible, try to have a drills on it within smaller group. Even you can have a smaller exercise, simulation exercise, even competition for that. Incident which is acted is prevented. And the most important part is it should be communicated. Lessons should be communicated. If it is not, then we are ready for the next disaster to happen. Thank you.
Thank you, Ujjwal bhai. We go on to the second session. I invite Dr. Puresh Umarania to talk about medical emergencies, do's and do nots.
Sir, excuse me, sir. Before we end this session, I would like you to present a memento to our speaker, Dr. Ujjwal Shah. Mr. Ujjwal Shah.
We invite Dr. Purvesh. He is going to talk about medical emergencies, do's and do nots in factory.
And, here I would like to mention this session is sponsored by BAPS Hospital.
Morning everybody. At the outset I would like to thank Indian Association of Occupational Health for providing us this opportunity, and today I am going to talk something about emergencies. I think we all deal with these emergencies day in, day out, whether we are working in the hospital or in the industry. It is an essential part of us. Okay. So these are the emergencies which we actually consider as an emergency. But today, what I am going to discuss about in detail is not about these emergencies individually. What are the mechanisms of this diagnosis which leads to the emergency? Actually, if you see, there is a spectrum of diseases which is there. If somebody comes to me and asks me that people with malaria can die, yes. People with malaria can survive, yes. So this is a spectrum of disease, as we have all encountered in last 2 years within the pandemic, that COVID patients can be treated at home. Many of them will not even realize that they actually contracted COVID and recovered, and they sometimes because of antibody will understand that I developed. And then there are certain patients who get admitted and within 3 days they expire. So emergency and disease go hand in hand, but we need to identify what is actually thing which differentiates from mild disease to the severe disease, and what is termed as emergency, where we need to act fast, apply our brain, and if required shift to the center where it can be handled properly. So these are the emergencies which we see day in, day out. But what consists emergency? Actually, whenever emergency happens, we get overwhelmed. It overbears us. It owes us. And we actually sometimes, in the rush of an hour or incidents, we don't act properly even if we are trained. So, if we understand the mechanism by which this happens, any emergency or the disease which will lead to emergency, if we understand the mechanism, we will be in the best position to handle that. And out of my talk today, even if you understand these and the ensuing 2 slides, this actually summarizes my talk. So what happens is, whenever there is a clinical insult, say diarrhea, trauma, MI or burns, what happens is this is considered as an insult. Now body will try to rectify the problem. As happens with COVID or diarrhea, there is a blood loss. So body will cause vasoconstriction and try to maintain the perfusion, not BP. It will try to maintain the stroke volume or perfusion to the peripheries. So in insult, there will be some response or corrective measure from the body, even if we don't apply. That is called as a pre-shock state. And if we identify most of the problems at this pre-shock state, obviously there will be certain patient who will come to you in a shock state. There you have to act in a different way. But if we identify a crisis situation in this state, then we will be able to save more and more patients. So this, if a condition actually goes from here to here, mortality from pre-shock to shock, it will lead to end organ damage and death. So at pre-shock level, survival probability is more than 75%. But once shock is developed, depending on the organ involvement, probability of survival decreases with each organ involvement. So this is very important. So emergency becomes life-threatening if we fail to identify a problem on time. If patient comes to you, contacts you not on time, then it is not your problem. But at the moment, we need to understand that shock can progress, right? So insult, then body's response is a pre-shock state, and if we do something at this stage, then we will actually not allow patient to develop shock. And what is shock? Shock is a circulatory failure. Circulatory failure doesn't mean that patient should have tachycardia or hypotension, something like that. It is a state of hypoperfusion, and hypoperfusion means tissues or cells are deprived of metabolic things like oxygen, glucose, ATP. So what happens is, tissue hypoxia develops, and then gradually metabolic acidosis and organ failure, and then ultimately death. So tissue perfusion is hampered because if oxygen is not delivered properly, or there is increased oxygen consumption or increased oxygen utilization. And if these things develop, then what happens? Patient develops some signs and symptoms. So patient will develop tachycardia, tachypnea, hypotension, hypoxia. And what are the symptoms? Patient is having altered mental status and oliguria. Patient is complaining of chest pain 1 hour before he is into your observation room. ECG is showing ST elevation or ST depression, global ST depression, and probably half an hour, 1 hour later, patient develops altered mental status. Means you need to understand that even if BP is normal, patient is developing signs of hypoperfusion. In presence of brain injury, these things may not apply, but when patient was conscious at the point of contact and then develops altered hypotension, you think you should think that patient is developing shock. So what are the mechanism of shock or any kind of emergency? We need to understand that if perfusion is not there, that means common example કે તમારા ઘરના નળમાં પાણી ના આવે તો what are the problems? Whether the tank is empty, a motor is not working properly, or downstream નળ block છે, નળ leak થાય છે. So these are the three mechanisms which we need to understand. So cardiac output means perfusion is affected because of these three things. Stroke volume is affected. One is preload, then contractility of, so blood volume is less because of hemorrhage or diarrhea or something like that, non-traumatic, traumatic blood loss. Sometimes mechanical obstruction to the heart like pulmonary embolism, cardiac tamponade, pneumothorax, all these things will actually decrease the preload. So tank is empty or water or blood is not moving forward, then there is contractility problem, MI, arrhythmia or something like that, and then there will be leakage from the downstream things. So these are the mechanisms of shock which we need to understand, and based on this, any diagnosis which I have shown in the previous slides about the emergencies, whatever you say, snake bite, burns, anaphylaxis, MI, polytrauma, anything you take, and ultimately if you identify the problems, that what was the upstream problem, whether it is a contractility problem or downstream problem of capillary leak, then you will be able to handle emergencies in very easy manner, even when there are a disaster like situation and hundreds of patients are there. So what will be the initial approach to any kind of emergencies? Whenever you approach patient with the emergencies, you just need to talk to patient. How are you? If patient is responding, that means first thing you have understood that patient is conscious and patient is not into shock. So now even if blood pressure is low, you can start acting immediately. If patient doesn't respond, then obviously you will follow this ACLS and BLS algorithm. So what is that? If patient comes to you or patient is unconscious, what is your first step? You check the consciousness and you check the pulse. So at the very least, if patient is not responding, you go and check patient's carotid pulse. If it is not there, then patient is in cardiac arrest, right? So this is the most stifling emergency. We need to immediately start cardiac massage, and out of this, most important thing is cardiac massage. If all step you don't know anything how to perform CPR, most important thing is if patient is not responding and carotid pulse is absent, means you need to do CPR. And CPR, most important thing in CPR is not intubation, not oxygen, not IV fluid, only cardiac compressions. So if you do cardiac compressions at 100 per minute, you are doing your job very properly. So first important thing is to identify whether patient is in cardiac arrest or not. So first step about treating emergency is this: check for consciousness and check the pulse. If patient is conscious, then obviously pulse and blood pressure you can measure. But if patient is unconscious, check the pulse. If pulse is absent, CPR. If pulse is present, then yes, hypoglycemia, stroke, IC, H, anything, convulsion, other things obviously comes into picture. But if patient is unconscious, if you think that airway is compromised, you intubate. Otherwise in CPR also for first 15 minutes you don't need to secure the airway unless you suspect that there is a foreign body aspiration. Then clinical examination, you take IV access, then detailed history and investigation. If patient is having any signs and symptoms of shock, then this is the algorithm you will follow, that you need to secure airway, other person will take IV access, and then detailed history and then investigation follows. So if any kind of emergencies, primary survey and primary treatment at your door begins with this. With this, I would like to give you few examples. I don't think I need to go into detail about any kind of emergencies, but this should be our approach. Look for consciousness, check for pulse, blood pressure, and based on the certain subtle clues, you come to diagnosis and treat accordingly. See, I think these are the things which will be available easily on the internet. I have just actually tried to summate all these things, but anaphylactic shock, we need to understand there are mechanisms. Mechanisms which will lead to anaphylaxis and then to shock. So what are they? If there is some bee sting, insect bite, or some drug reaction which will lead to anaphylaxis, seafood, something like that. See, we need to understand that anything on this earth can lead to anaphylaxis. People can be having reaction to anything. I have seen people reacting to wheats or chocolates also. So we don't need to think that this cannot happen, or this can happen only in certain specified situation or certain specified stimulus only. So what we will do in case of anaphylaxis, commonly we use injection, phenyramine or promethazine or Avil or something, but we need to remember that it just blocks H1 receptor. Anaphylaxis happens because of excessive histamine release because of allergy to certain stimulus. So H1 blocker are all our anti-allergic medicines, but we need to give them H2 antagonist also, so that all the histamine release from the body is blocked. So H2 antagonists are our common antacids, ranitidine, famotidine or something like that. Ranitidine injection is easily available. And if patient is developing further problems, patient says breathing issues, or patient says that I am unable to speak, then histamine release causes lot of edema, peripheral as well as laryngeal edema. So you need to secure airway before it is too late. Otherwise you will not be able to intubate patients, and we have to have a tracheostomy, which facility for which may not be available everywhere. So anaphylaxis, most important thing is H1, H2 blocker. If patient is developing severity, then steroids and adrenaline. I think you all should have these injections available into your day-to-day practice or in your clinic. If patient is developing hoarseness of voice, immediate intubation, because edema in first 24 hours is going to increase only. Further, if patient develops hypotension, then vasopressors are also required. So this is most important thing. Histamine release causing vasodilatation and edema, peripheral as well as laryngeal edema. Most likely, if patient is treated on time, outcome is 100% positive. Then acute coronary syndrome means acute MI. I think I don't need to tell you much about this, but cardiogenic shock, again as I told you, any kind of shock, we need to see the vital parameters, history and symptoms. If patient is having any severe symptoms, altered mental status or perfusion related any kind of problems, you need to handle immediately. So just ECG and then transfer, no. At your center also you should start certain things. Even in patients with cardiogenic shock, if it is a right inferior wall MI, you can give fluids. Even if it is on the left side, patient may develop pulmonary edema, but to stabilize the blood pressure, you can give some fluid or start with some vasopressor and then transport, because it may take 1 or 2 hours, and by that time shock may worsen. Ultimate treatment obviously is thrombolysis or percutaneous coronary intervention, but here we are talking about dealing how to emergency patients at your doorstep, right? So if history is significant in patients with high risk, and ECG obviously all of you can read, and patient develops certain symptoms, it is a contractility problem. So pump here is failing, right? Then aortic dissection, I don't think you see all these problems very frequently, and again it is not a very frequent problem. But how do you identify the problem? The most important clue here is, if you check pulse and blood pressure, you will feel the intensity of pulse is different in both the hands, and blood pressure also is different. Means on one hand blood pressure may be 150 and on another hand blood pressure is 110, then immediately you should think about this disease, right? Again, hypovolemic shock, most common emergencies I think we handle or we actually come across in our day-to-day practice. Hypovolemia can be because of two things, traumatic and non-traumatic. Traumatic means, as we all understand, hemorrhage, any trauma, any other injury, fall. So these are three types of hemorrhages: external, internal and fractures. So external hemorrhages from skin or CLW are compressible. So you can stop bleeding immediately. If there is a penetrating wound leading to visceral injury or vascular injury, they are not compressible. So you need to send them urgently to the higher centers. And then there are fractures. The bleeding from the bone will continue, but at least if it is open wound, or if you stabilize the fracture in one position, at least you will actually partially stop the blood loss, right? then there will be burns where hypovolemia is because not the external blood loss, but patient's intravascular body fluid is traveling or migrating to the extracellular fluid or interstitial space. So this is called as third spacing. Again, in high cervical cord injury, neurogenic shock develops because of the peripheral vasodilatation. And certain toxins, medicines, all can cause relative hypovolemia. Fat and air embolism will cause obstruction and peripheral vasodilatation. So these are the non-traumatic things. Most commonly what we come across is loose motions, vomiting, hematemesis, bleeding diathesis, or sometimes because of anticoagulants, blood loss. These are the common things which we come across. But if patient has come to you with signs of shock, immediately start IV fluid and then shift to higher centers or start treating. So here most important thing is to stop blood loss. If diarrhea and vomiting is there, again you need to find out that what is the reason for diarrhea and vomiting. You start acting on that and simultaneously give fluid resuscitation and peripheral fluids. If you control the source of hypovolemia, then I think you are in better position to control the hypovolemic shock. So these are certain things which we need to look at. This is the cartoon which shows that decrease in body fluid happens because of very varied causes. Again here the diabetes insipidus or diabetic ketoacidosis also can cause hypovolemia because of excess sugar leads to polyuria, right? Arrhythmias, again you don't need to identify what arrhythmia is there, you just need to see that arrhythmias are severe enough to cause signs of hypoperfusion. So if atrial fibrillation is there, most likely it will not lead to hypotension or signs of hypoperfusion or cardiac arrest. But if arrhythmias of ventricular origin, ventricular tachycardia or ventricular fibrillation, it most likely patient will develop arrest or hypovolemia. There you need to act fast and immediately. So you need to have a defibrillator. You just need to identify one or two arrhythmias like ventricular tachycardia or ventricular fibrillation, and you immediately can handle the patient, and then workup can ensue. Because ventricular fibrillation, ventricular tachycardia, most likely patient will be in shock or cardiac arrest situation, right? So defibrillation here becomes very important. You need to learn that and you need to practice that. So last two types of shock, obstructive and septic. So most common obstructive shock means preload. So vascular feeling is good, contractility is good, but blood flow is not happening to the heart because certain obstruction is there. And here it is there in form of pulmonary embolism. As you can see in CT scan also, you can see the saddle embolism. So how do you diagnose this? I think here the only clue will be the history. Otherwise, from tachycardia or hypotension, hypoxia, you will think pneumonia, UTI, heart disease, anything else. But here the most important thing here is the history. A patient had a surgery in recent past, patient had high risk factors of malignancy or something, or patient had a recent history of travel in long flights, say 10, 18 hours at one go America, she has traveled or came back from there, and patient had high risk like obesity, prothrombotic state. So this is the clinical history which I am talking about. If you take focused history and simultaneously with that look for the signs of hypoperfusion, you will be able to clinch the diagnosis. A treatment, again, thrombolysis if patient is having severe problem, otherwise anticoagulation. Cardiac tamponade, this is important because trauma is very common happening in occupational health or industrial problem. So trauma can lead to hemorrhagic pericardial tamponade, and which will cause hypotension and shock. So what you need to see is, one, the backstride, hypotension, muffled heart sound. If you see the normal heart sound which are not audible properly, any kind of heart sound, and patient is having hypotension but conscious, simultaneously with raised venous pressure in the neck, jugular venous pressure, then that will be the clue that patient had a trauma, or patient even had a MI. That also can lead to pericardial tamponade, or patient had percutaneous coronary intervention 10 days ago, now came with hypotension, and if ECG is okay or low voltage, not showing any signs of stent restenosis, then cardiac tamponade is on the cards. You just need to see muffled heart sound with proper background history. Again, the important thing is to decompress, not anything else. So under echocardiography guidance, you need to do pericardiocentesis. Pneumothorax, again simple pneumothorax will not lead to any symptoms, but in trauma, if patient had underwent any kind of pleural intervention or bronchoscopy and patient develops breathing difficulty, hypoxia, then you suspect tension pneumothorax. See, tension pneumothorax is different from simple pneumothorax, as in it will lead to obstructive shock. That means blood going to heart will be obstructed. So again, ICD is very important. Sepsis, two things. One very important thing is very overdiagnosed thing or underdiagnosed thing, I am not sure. But important thing is temperature doesn't have to be high to have a diagnosis of septic shock. Almost 1/3 of patients with sepsis presents with septic shock when their temperatures are lower than normal. So at least 35% patient will have normothermia or hypothermia. So if fever is there and patient develops shock, yes, you all are aware that it can be septic shock. But even if patient is having normothermia or hypothermia, sepsis can be there. And most importantly, in altered mental state. If you see that patients are elderly and patient comes with you without any problem but just altered mental state, there are only two things on card. If there is dyselectrolytemia or if there is any kind of infection. If that kind of patient is progressing towards shock, then you think about antibiotics and fluid resuscitation. So I would like to leave you at this. I don't think this is legible slides, but most important thing today, what I would like to tell you is any kind of emergency from normal disease, progression to emergency happens through this route only. If you identify patients at a pre-shock level, then you will be able to save many more lives. Thank you, everybody.
So, may I request the chair to give a token of appreciation to the speaker? I again convey my sincere thanks to our sponsor, BAPS Hospital, for this session.
Good morning all. We have an important announcement. Because of the excess delegates registered in last 3 days, we have made a temporary arrangement on first floor Emerald Hall. We can accommodate about 60 guests in that hall. So I request all those delegates who are standing and outside, please proceed to the first floor. The same conference will be streaming over there, and about 60 delegates can sit in that room, and it is ready by now. So before next session, those who are standing or unable to get chairs here, they can please proceed to first floor Emerald Hall. Thank you, and sorry for inconveniences.
Thank you, Milan. We go on to the next session, which is very important for all the stakeholders of occupational health, maybe factory medical officers, maybe HS, or maybe people from HR. We have us a very eminent person from the industry of Gujarat, Sri Mr. Atik Desai, sir. On the behalf of the organizing committee, I invite you to make a presentation on legal aspects of occupational health. Atik sir is an engineering graduate from LD Engineering College, Ahmedabad. He started his industrial career with companies like Bartley Boy and Rallis. He has a long experience of 32 years working for the giant Indian MNC L&T. Atik Bhai is a member of various professional bodies concerned with the management industry. He was very instrumental in getting British Safety Council to his organization L&T, a very prolific reader and a very knowledgeable person. On behalf of the city of Vadodara, sir, on behalf of IOH, I invite you to make a presentation on a very pertinent topic, legal aspects of occupational health. I present you Mr. Atik Desai.
Good morning. How are you all feeling? Excited? 2 days of learning. So thank you, Dr. Jagdish Kamath, Dr. Jayant Patel, and all the learned people gathered here. I am not an expert on the subject, but I will try to cover whatever little I know on the subject. Pardon me if I am away from something which you feel should have been covered. But I will try to give you whatever learning we had at our Larsen and Toubro Hazira Manufacturing Complex, which is now called as AM Nayak Heavy Engineering Complex. It is a 755 acres of land and 10 different manufacturing units with daily footfall of around 20,000 people inside the campus. And we have to be careful about various legal aspects. So I will cover first in brief what is the background of the subject and then take you through a couple of challenges which we face in our country. India is, as we all know, is a nation which is now coming in the reckoning as a developing nation, but we have lot of challenges on legal front in factories. As we all know, occupational health is defined as the highest degree of physical, mental, and social well-being of workers in all occupations. Now, worker is a generic definition. Everybody which works in the factory is a worker. Deals with all aspects of health and safety in the workplace with strong emphasis on the prevention of hazards at a primary level. The approach has to be proactive. When you are proactive in your approach for well-being of your workers, then in that case you can also remain cost-effective, and a country which cannot afford very heavily, because industries, if you see as such, they struggle to make profits. And when they are making profits, the tendency is to spend minimum on the legal aspects. Wherever shortcuts can be taken, people try to do, except few organizations which are really good at it. History of occupational health in India. Movement of occupational health may be now little over 3 decades old, though labor management is more than century old. Now, if we look at Bombay Mill Hands Association, formed by Narayan Meghji Lokhande and his colleagues, for the first time they demanded a weekly holiday in textile mills in 1880s. And if a weekly rest is considered occupational health issue, then the movement is century old. And we all know that how important weekly off is in industry today, thanks to Narayan Meghji Lokhande, who started this whole thing. First trade union was formed in 1920 and Trade Union Act was enacted in 1926. Trigger point, Bhopal gas tragedy, 2nd December 1984, Union Carbide at Bhopal. We all know what kind of gas tragedy it was. And actually that spurred more thinking on legal aspects across factories. And this particular aspect came into light, and we all today worry more about it than ever. Need of legislation for labor law. It provides framework within which employers, workers, and their representatives. Now so-called we call them union or joint management council members, can interact with regard to work-related issues. It serves as an important vehicle for achieving harmonious industrial relations. It constantly reminds us of fundamental principles of workers' rights and employers' responsibilities. As we all know that till we are able to support others, we can say we are helping the society. But the day we become handicapped in any way, while working in industry, we know that we become dependent on company, co-workers and families at large. So it's a very, very important factor we all should keep in mind while working in society or in factories. Need of legislation for occupational health. Many workers employed in unorganized sectors are not coming under the purview of Factory Act. As we all know, MSME sector or GIDC per se, the kind of factories we have, the kind of facilities it can provide, and the kind of employment it generates, all put together, it needs a lot of thought processes, and we all need to awake ourselves for doing good for the society at large. Majority of industries can neither afford nor interested in giving total health care to their workers. History reveals industrial revolution in West paid heavily as compensation because of ill health, accidents, deformities, tuberculosis, etc. And we all know that West is much more aware about all the aspects, and the laws are very stringent as compared to what we see in our country. But our country is not far from enacting those labor codes which are going to make it compulsion for everybody to fall in line. Occupational health legislation in India. The government of India enacted 4 labor codes consolidating 44 existing labor laws. First one is the Industrial Relations Code 2020, which is going to be enacted soon as it appears. The Code on Social Security 2020. The Occupational Safety, Health and Working Conditions Code 2020. The Code on Wages 2019. Currently, the Factories Act 1948 and the Mines Act 1952, containing the main provisions for legal measures for the protection of health and safety of workers. The Factories Act was amended in 1987 and stipulates pre-employment examination as a precondition, pre-placement procedure or statutory periodic medical examination for jobs in hazardous areas across industries. Occupational health legislation in India. The Ministry of Labour and the Labour Departments of the states and union territories are mainly responsible for health, safety and welfare of workers. However, we in industries, we cannot say that everything is government's responsibility. Whatever compliances are to be met, we need to be aware of it and we should comply with it. The Ministry of Health and Family Welfare is responsible for providing health and medical care to workers through its facilities. If we look at the DGMS, that is Directorate General of Mines Safety, and the DG FALSI, that is Director General, Factory Advisory Services and Labour Institutes, assist the Ministry in technical aspects of occupational health and safety in mines, ports and factories, respectively. If we look at labour laws, which were mentioned few minutes back, that 44 labour laws are now being covered into 4 codes. So, if we recall some of them, like Workers' Compensation Act 1923, Trade Union Act 1926, Payment of Wages Act 1936, Industrial Employment, that is Standing Order Act 1946, like that, the list goes on and on till 44. Occupational Health Institute, I think you are taking photograph. You can. No, you can take it. I'll move them. Okay. So, occupational health institutions in India, the National Institute of Occupational Health, that is NIOH, was established in 1970 at Ahmedabad, Gujarat. Many of us may not be aware of this. And there are 2 regional occupational health centers, ROHCs, have been set up in Bangalore and Calcutta. The National Safety Council of India was established to promote safety consciousness among workers to prevent accidents, minimize dangers and risks, and arrange related education and awareness programs. Central Labour Institute and its associated institutes and the All India Institute of Hygiene and Public Health educating doctors for occupational health and hygiene. AFIH, PGCIH, CIH, these are the various institutes which are taking care of health and hygiene. These are the some of the legislation under Factories Act. Now, if we look at cleanliness is covered under Section 11. Employers should provide hygienic workplace and maintain cleanliness. Now, many industries, when we enter, it is said that Japanese employers or entrepreneurs, whenever they visit any factory, first thing they look at is the housekeeping. And that is where they judge the company, whether this company should be done business with or not. Disposal of waste and effluents, Section 12, this has become very recent, and after COVID, it has become more in light that disposal of waste is a very, very critical aspect and effluents. Effective arrangements shall be made for disposal of waste and effluents arising from manufacturing processes. Some of the industry uses some hazardous chemicals and also have occupational health centers. So these industries need to be more vigilant on hazardous waste. Ventilation and temperature, Section 13, it goes without saying. We in a country where we live in 44-degree temperature, 45-degree temperature, nothing happens. Whereas in Britain we read, day before yesterday it was in newspapers, that at 40 degrees centigrade temperature, the wooden houses started getting burnt. And there was a total chaos in the city. Schools were closed. All such things keep happening. So, adequate ventilation to be maintained at the workplace, ensure comfortable temperature for safety of persons working in high temperature zone. Provide PPE where necessary. PPE means personal protective equipment. They are very important in industry. Helmet, goggles, also safety shoes and hearing aids wherever noise levels are heavy. Legislation under Factories Act, further, dust and fumes, adequate measures shall be taken to prevent if any process has formation of dust or fumes, its inhalation can create serious health problems, and we need to be aware of it and take enough precautions if we are in industry. Exhaust appliances shall be applied as near as possible to the point of origin of dust or fume. If you anytime get an opportunity, I would like to invite any one of you to our Larsen and Toubro AM Nayak Heavy Engineering Complex. Dr. Jayant Patel will coordinate the visit with Dr. Tejas Wasi was here. So they can organize your visit, and it is very interesting to see how heavy engineering industry operates in complying with all these kind of requirements. Artificial humidification, section 15.19, use clean and pure water, drinking water for creating artificial humidification. Legislation under Factories Act, further, overcrowding should be avoided. Section 16 says that space for a factory worker shall be provided at the rate of 14.2 cubic meters per worker. Now, many of us may not be aware. In a small factory, we try to crowd many workmen, which is not a good practice. We need to follow this compliance. However, it is very difficult to comply with in GIDC or MSME sector. Space 4.2 meters above the floor is ignored for this purpose. So 14.2 meters, when we talk about cubic meters, it is only below 4.2 meters of the floor height. Lighting, section 17, the management shall provide sufficient light, natural, artificial, or both as per the defined lux criteria. Nowadays, there are transparent seats also available, so some part of the roof can be covered with transparent seats, and it can help us follow the norms. Drinking water, section 18, it's very basic. It should be sufficient, wholesome, and provided at convenient places. All water points be marked as drinking water and not to be situated within the 6 meters of washing place, latrine or urinal. It should not be so near to that. If more than 250 workers are employed, cool water to be provided in hot weather. We should have coolers, water coolers in the premises if we have more than 250 workmen. Latrines and urinals, section 19, again provision of clean and well-lighted toilets and urinals. The number of latrines and urinals according to factory rules under Factory Act to be provided for men and women separately. Now in diversity and inclusion era, it has also been made mandatory that for every 20 female workers, there has to be one urine and toilet separate for them. So wherever we don't have in those factories, we need to fall in line. Even the recent concept says that for female workers, there has to be a wellness room provided in the factory. Now this is difficult to afford, but at least big industries should take the lead and become role model in this direction. Provisions of spittoons, section 20, provisions under welfare, washing facilities, facilities of sitting place should be provided, suitable arrangements. everywhere, wherever the working is in standing position. Legislation under Factories Act further, first aid appliances, section 45. Now this is one weak area in many industry, because what happens is wherever you provide the first aid box on the shop floor, if you leave them open, whatever medicines or first aid treatment boxes you provide, in no time it vanishes and you don't know how to control it. So if the responsibility is given to the supervisor or shop in charge in that area, then probably occupational health center individuals can help control this aspect better. Canteen, section 46, provision for canteen services if more than 250 workers are employed. This is another area where I can say with pride that L&T Hazira, which we started, where we started commercial production in 1985, it is now almost 15 plus 22, 37 years old place, and till date we have not had any food poisoning or anybody falling sick because of food in the canteen. Till date, that is our record at Larsen and Toubro. Shelters, restrooms, lunch rooms, all need to be provided. Crisis, this is another important provision in the law, and we need to all comply with this. Section 48 says adequate lighted and ventilated crash facility to be provided, because when the female worker has young children, they need to be taken care, and company has to make a crash room and also provide adequate female caretaker there to take care of the children while the lady workers are performing their duty. Welfare officer is required in a company if number of workers are 500 or more. Working hours for adult, again section 51 and 54, it should not exceed 48 hours. Beyond that, it has to be overtime or compensatory off as applicable in that workplace. Weekly holiday is required as per section 25, and some places have staggered weekly off because of the power cut situation in that area. Daily hours not more than 9 hours a day for working, including breaks. Interval for rest, section 55 and 56, not more than 5 hours work at a stretch, followed by rest for at least half an hour. See, this is another area which is important, because some continuous process plant machinery or equipment may be running for more than 24 hours also continuously. But we need to make sure that whoever is the worker or attendant there need to be given a rest after 5 hours. Women workers, section 66, no woman to be employed between the hours of 7 p.m. and 6 a.m. This is a question mark, because now the industries are changing and female workers are also getting duty in the night hours with all the facilities provided by company, including female guards in security. Provisions under employment of young persons, section 67-71, no minors should be engaged for work, in no case less than 14 years. Occupational Health Center 68U, in respect of any factory on hazardous process, there shall be provided and maintained in good order an occupational health center with the service and facilities. Recommendations are given based on the number of workers up to 50, 51 to 200 and more than 200. Even big industry need to have ambulance van, and it should be there in the factory premises. Any factory which is carrying hazardous processes need to have ambulance within the factory and maintained in good condition, suitably constructed ambulance van equipped with all required items and manned by a full-time driver cum mechanic and helper trained in first aid for the purpose of transportation of serious cases of accidents and sickness. Now, occupational health services, predictive health care, occupational health compliance and employee welfare. If we look at this, there are various things we need to be careful about, and we are very careful about this in our complex, our premises, where we have more than 20,000 footfall daily. So 24/7 health service, general sickness, accident cases, pre-employment medical examination, periodic medical checkups for everyone, and we ensure PDCA, that is Plan, Do, Check, Act cycle, for ensuring that all the periodic medical checkups are done without fail. And top management has to be submitted the report by the Occupational Health Center that how many people are balanced and why they are not going for their medical checkup. And if they are not going, then they are forced either through company employees or through their family members. First aid and CPR vaccination. Predictive healthcare, we also do trend analysis, health index, season-based sicknesses, if any, occupational health awareness, health camps, then compliance to general factory rules, Form 20, 32, 33, 37, audit ISO standard, biomedical waste disposal, industrial hygiene, certifying surgeon, accident reporting, mock drills. We also have panel hospitals and panel doctors in Surat city. Same thing is true for our Vadodara campus also. Employee welfare, we have done cashless hospitalization for all our employees and contract labor through their contractors. IOU management, that is if any advance to be taken for treatment. Safety goggles, power glass, LTD management, that is life-threatening disease. We have schemes in our company for life-threatening disease. We have company employee welfare scheme where up to 8 lakhs we cover. We also have employees created natural death relief scheme and mutual relief scheme. In case of accidental death outside of a factory worker, we contribute them through collective funds. That is also there in place. We have hospital empanelment, as I told you. Hospital visits are regular if anything which cannot be treated within occupational health center facilities and equipment. Blood donation drive we take every year. So the biggest benefit of that is what? That when we donate blood to local blood banks, when we need any blood in case of any accident or emergency for our people, we get it easily, and in a way it also provides some rare blood groups donation to society at large. Health awareness campaigns, our team is so proactive, and they release many advisories. Now, right now there is a monsoon season, so before the monsoon sets, there is an advisory to employees what kind of care they should take in terms of water or any other waterborne disease, airborne disease, mosquitoes, how you should take care of all those aspects at company as well as at home. assistance in disablement, for disablement certificate if somebody loses some part of the body in accident. Now, these are some of the things which responsible corporate citizens should do, and we have done it. During COVID pandemic, as you can see, we provided all these equipments in Surat Civil Hospital as well as Surat Municipal Corporation Hospital as well as Navsari also. We covered even Baroda, our company covered many industries, Rajkot as well as Gandhinagar, Sanand, we covered many places like that. So advanced life care support ambulance we gave, biomedical waste van. Now you will be surprised that knowing this, that biomedical waste for COVID patients as well as normal patients used to go together from Civil Hospital Surat. The moment we identified that, the first thing we did as a corporate, responsible corporate citizen was to provide biomedical waste van exclusive for COVID waste. And that was handed over to Madam Jayanti Ravi, Principal Secretary Health of the state. Similarly, we also found there was a biochemistry analyzer which helps clear diagnosis, was provided to the hospital. It was at 35 lakhs cost. Another thing, what we found, that washing area had a mix-up of COVID, non-COVID patient clothes. So we decided to provide fully loaded automatic washing machine for COVID clothes separately. Now these are certain basic things, but we forget it. Now high-end ultrasonography machine for fetal medicine department was also provided at Surat Civil Hospital, and we came up with a unique idea in Gujarat that for COVID wards, why not we have robotic nurses? And we introduced that at Surat, Rajkot, Vadodara through our L&T Green Energy and Energy Division, hydrocarbon, we call it, through that division. High flow oxygen unit and multi-para monitor, we all know how it was critical. We provided at many hospitals in Gujarat state. Why I am sharing all this? Because it is very important that as responsible corporate citizen, we all need to contribute to the society, and we should think from the root. If we don't think from the root, the solution we provide will be donating masks, donating sanitizers, but that's not what we should be doing all about. We should go beyond. Support to nearby villages, food distribution, sanitization of the villages we carried out. Now we have one safety innovation school which is unique in Asia. And our previous CMD, Mr. K. Venkatramanan, when he went to Korea, he saw a safety innovation school. And we introduced this at L&T Hazira. Now many multinational corporations take our help in training their engineers, like companies like ExxonMobil and many Indian companies also. So this is one thing which is worth visiting if you happen to be in Surat and you feel like visiting L&T Hazira and see our safety innovation school. It is another place which is worth seeing. You can't invest so much money. It is understandable. Every industry cannot afford unless they are big enough. But it is worth seeing and getting people trained there. So these are some of the pictures, what all kind of falling from height and other many important things. So today when we talk about challenges in India, a very large proportion of the workforce is in the organized sector. Ineffective and incomplete implementation of this legislation is a major constraint, and mainly not because people do not want to do. It is mainly because people feel scarce of resources. Lack of trained occupational health manpower is another area of concern, and even if they are available, many industries can't afford it. High unemployment level and exploitation of workers is still there to a large extent in our country. Slowly the country is waking up, but we need to travel a very long distance. Undiagnosed and unreported occupational illnesses lead to a lack of accurate information and data on the scope and extent of occupational diseases. Many times what happens, if somebody develops some minor problem in the body, they feel कि कुछ नहीं है, चलता है, हो जाएगा ठीक, let me not worry too much. And we feel afraid of contacting doctors. And when we do that, we don't know that we are slipping into a bigger problem later. So it is important that we bring awareness amongst the factory workers, be it workmen, be it managers, be it supervisors, everyone around. We bring awareness that stay healthy and make sure that we all grow together and keep glowing forever. Thank you very much.
May I request the chair to present a token of appreciation to our speaker? This will be the last session before lunch today.
This is the last session before lunch, and this session is sponsored by SCG Hospital, Baroda, and our speaker is Dr. Sachin Wani. He is consultant surgical oncologist and he specializes in head neck surgeries. I invite Dr. Sachin Wani.
Today morning. My name is Dr. Sachin, and I have a disclaimer to make that I am not an occupational health specialist, and my today's topic is occupational cancer. Although in experience and in my work profile, I am a practicing oncologist. હું એક કેન્સર સ્પેશિયલિસ્ટ છું, occupational cancer specialist નથી. અને during my practice of oncology, what I perceive as occupational cancer and what we should know about occupational cancer, I would be presenting that in next 20 to 30 minutes. So what I'll talk about, cancer is not a unknown word to doctor or non-doctor in the audience. Everybody has seen a cancer patient in their clinic, in family, friend, community, neighborhood. So last 30 years what is happening in our country. I am sure we know that incidence of cancer is increasing. We now know more and more people suffering from this disease. We have 4 or 5 cancer hospitals in the city. 10 years back we have only 1. So certainly there is something happening here. So I'll talk about that. Then how occupation and environment affects the incidence of cancer. હવે જે વાતાવરણમાં આપણે રહીએ છીએ, જે શાકભાજી ખાઈએ છીએ, જે એર બ્રીથ કરીએ છીએ, એ આપણા હાથની બહારની વસ્તુ છે, પણ હાઉ ઇટ ઇઝ ઇન્ફ્લુએન્સિંગ અકરન્સ ઓફ કેન્સર. એમાં આપણે શું કરી શકીએ, વોટ વી કેન ડુ, આપણે શું ના કરી શકીએ. અને લાઇફસ્ટાઇલ આઈ ફીલ ઇઝ અ ઇમ્પોર્ટન્ટ પાર્ટ ઓફ એવરીવન્સ ઓક્યુપેશન, because 60 hours in a week we spend working, and other major part of the week we spend sleeping. So main part of our life is related to occupation. So lifestyle and related cancer also I'll touch base on. So how occupational cancer has direct or indirect relation with means what are the factors which leads to occupational cancer? Most common is exposure. Some exposure to a chemical agent which you can't avoid being working in certain industry, like asbestos, chemicals like aniline, dinitrotoluene, cadmium, nickel compounds, wood dust. So these are exposure related cancers. If you are working in certain industry, then certainly there is an added risk of somebody suffering from this type of cancer because of exposure. Second is environmental factor. As I mentioned about air pollution, water pollution, soil pollution, how it will affect chances of suffering from cancer. And third, I said lifestyle, which includes alcohol, tobacco abuse, diet, sleep pattern, personal habits, exercise, not doing exercise. All these are lifestyle factors. So these mainly three factors which makes an individual prone to suffer from cancer. આ 3 ફેક્ટર મેઇનલી ઇન્ફ્લુઅન્સ કરે કોઈ વ્યક્તિને કેન્સર થશે કે નહીં થાય. તો એક એક કરીને વારાફરતી આપણે આ 3ને ટોપિક ટચ કરીશું. અને ટુ માઇન્ડ યુ, ઇફ somebody is able to take care of these 3 factors which I just mentioned, exposure, environment and lifestyle, you can avoid 75% of cancers. So it is not that કે ભગવાને આપ્યું એટલે થયું કેન્સર. 75% cancer are directly or indirectly related to your exposure, your environment, and most important, your lifestyle. So one is able to control 3 factors, you can control 75% of cancer. So talking about exposure, as I said, it is directly related to exposure of chemical, dust, radiation, and some industrial processes. Exposure to chemical oncogene can cause mutation. કોઈ chemicalના exposureથી બોડીના સેલ્સમાં mutation થાય, which becomes out of control, leading to cancer. This is how it happens. And lot of chemicals used in surrounding industries, which are common industries. We have pharmaceutical, rubber, chemical. So a lot of chemical used in these industries are actually carcinogens. So which are the common cancers as per books which occur because of occupation? The most commonly mentioned cancer which occur because of exposure to chemicals are carcinoma bladder, એટલે પિશાબના કોથળીનું cancer, kidney, leukemia, and another lung cancer is increasing, may be related to exposure of certain chemical in industries as well as environment. Lymphoma, mesothelioma, nasal cavity, sinus and skin. And as an oncologist I would tell you, this group forms very, very small part of actual oncology. The majority of the cancer અમે જે cancer hospital માં જોઈએ આમાંથી કોઈ નથી. Although central Gujarat is filled with industries, we have foul smell coming in different seasons because of some chemical leaks in surrounding industries. And it is perceived that we are seeing more cluster of cancer because of exposure, but it has not been seen, at least not in cancer hospitals. So fortunately, at least books mention that all these carcinogenic agents are banned. Again, I said that I am not an industry expert, nor a guy from government agency, nor somebody who will make a regulation. So I can read book and say that most of the chemicals which are carcinogens are banned from usage in industries. So when talking about industries, talking about occupation, exposure is one important part which will cause cancer, as we know. Now what are the other related factors? Working somewhere, shift work. I don't know how many of you know that shift work is also important cause for breast cancer. Why does it happen? The exposure of light during night and disturbed circadian rhythm increases chances of somebody suffering from breast cancer significantly. Stress. Stress doesn't have direct relation with cancer, but because of stress, my friend started eating tobacco, consuming alcohol. So indirectly, stress also leads to increasing incidence of cancer. And sedentary work, I'll talk about it at length. Now coming to environmental pollution and cancer. Again, it is related to occupation, industries. With more and more industrialization and migration of people to cities, a large number of people are at increased risk of developing cancer, which happens because of environmental pollution. And it is interesting to note, today in India, if you count, 130 to 140 person out of 1 lakh would suffer from cancer in their lifetime. That is incidence of cancer in our country. And you know, it has started increasing since when? It started increasing since the time our economic liberalization happened in early 90s. Maybe before that we had almost 1/3 incidence of cancer. So with industrialization, with liberalization of economy, we have got more and more small scale industries opening up, and the effluent from those industries are actually causing certain cancer, which probably will come to know after some time. So cancer trends in India, there is significant increase in incidence of breast cancer in urban India, and increasing incidence of lung cancer, colon cancer in urban India. Few of the cancers are directly related to increasing industrialization, increasing workforce living in urban population. Both trends are related to urbanization, increasing modernization, lifestyle, and longevity. So water and air pollution, and what is the overall scenario? See, as I said, when India became industrialized, when foreign direct investment was increased, and when more and more industries started happening, Make in India campaign boosted that. We have hundreds of small-scale industries opening up in every part of the city and country. Because of this, there is alarming contamination of groundwater with heavy metals. And poor implementation, as we all know, we don't have to debate about it, and government guidelines. We are certainly seeing more number of cancer happening, which directly you may not blame one particular industry or an agent, but yes, it is gradually happening and it is not good. So if you talk about world's most polluted cities, so these are some 10, 12 world's most polluted cities. India features in most of the 1, 2, 3, 4, 5. So we top the list except one city from Cameroon. Rest of the most polluted city in the world are in India. So these are not just figures. See, they will ultimately influence your health. They are going to give problem to your health, increase incidence of cancer and other diseases. So recent link of air pollution. Now how can we link that because of air pollution, more people are suffering from lung cancer? Because lung cancer is attributed to smoking. So maybe increasing incidence of smoking is happening, that is why more lung cancer is happening. But there are certain correlations. See, recent reports from India suggest that there is changing pattern of lung cancer. Now we see more number of females suffering from lung cancer than what we used to see 100 years back. 3 out of 10 patients of lung cancer coming in our hospital had never smoked in life. So lung cancer happening because of no history of smoking is happening in more numbers. That is how we correlate that this comes from air pollution and not from smoking. Now in villages, હવે ગામડામાં બ્રેસ્ટ કેન્સરનું ઇન્સિડન્સ બહુ ઓછું છે. હવે અહીંયાથી 25 કિલોમીટર તમે બહાર જતા રહો બરોડાની, તો બ્રેસ્ટ કેન્સરનું ઇન્સિડન્સ બરોડા કરતાં 1/3 છે. તો આ ડભોઈમાં અને બરોડામાં બ્રેસ્ટ કેન્સરના ઇન્સિડન્સમાં ફરક કેમ છે? બધે we have same common gene pool. So again, the increasing incidence of some cancer in urban population also correlates with air pollution, water pollution, soil pollution. Lower risk of developing breast cancer in rural area compared to urban area. Also suggests that something which is happening in the city which is not happening in village is causing cancers. Now coming to tobacco related cancer, again this is not directly related to occupation. See, tobacco is a bad habit. No industry would encourage their worker to eat smoked tobacco. But most of the workers in working in any industry who consume tobacco, I feel that it is responsibility of that industry to look into the matter that more people use these vices less and less. In India, tobacco consumption is responsible for half of the cancer. If today government bans tobacco, maybe 10 years down the line we will see 50% number of cancers in our cancer hospitals. And highest incidence, like India is a capital of oral cancer. Oral cancer એટલે મોઢાનું, જડબાનું, જીભનું cancer. We lead the world in this disease. જેટલા પેશન્ટ આપણા ત્યાં હશે એટલા દુનિયામાં કોઈ જગ્યા નથી હોતા. That is again attributed to very peculiar use of tobacco. This is chewing tobacco. Tobacco as well as areca nut. Areca nut એટલે સોપારી. હવે most of the people believe કે મીઠી સોપારી તો છે, આમાં તમાકુ નથી. But IARC ના કાર્સિનોજનમાં it has been theoretically proved that sopari is equally harmful in causing મોઢા, જડબાનું અને જીભનું કેન્સર. એટલે સાદી સોપારી જેના ઉપર ગવર્મેન્ટમાં કોઈ બેન નથી, જે નોર્મલી આપણા ત્યાં પાનમાં નાખીને આપણે વાપરતા હોઈએ છીએ, એ પણ બહુ ઇમ્પોર્ટન્ટ કાર્સિનોજન છે. સો અગેન કયા કયા કેન્સર ટોબેકોથી થાય? લિપ, ટંગ, માઉથ, ગળાનું, સ્વરપેટીનું, ફેફસાનું, યુરિનરી બ્લેડરનું, લિસ્ટ અનગનત છે. અને આ જે કેન્સર છે આ મોસ્ટ ઓફ ધ કેન્સર હોસ્પિટલનું મેજોરિટી વર્ક છે. આજે જો હું સવારથી સાંજ સુધી અમારા હોસ્પિટલમાં બધા પેશન્ટ જોઉં તો 10 પેશન્ટ જો નવા આવે એમાંથી 6 પેશન્ટ ટોબેકો રિલેટેડ કેન્સરના હશે. તો ઇઝ ટોબેકો કન્ઝમ્પશન ઓક્યુપેશનલ હઝાર્ડ? I think you guys will have to tell me whether it is occupational hazard or not. And is tobacco de-addiction your work? Again, you will have to tell me that it is your work or not. I know a couple of good industries where they have adopted healthy practices, banned tobacco usage from the premises, have influenced suffering of their workers. So I firmly believe that a health worker working in industry has a lot to do with it. And by adopting de-addiction practices in the work, by banning usage of any kind of pan masala, sopari, bidi, cigarette in work premises, by not allowing smoking zone, we can make a small difference and gradually it will help us reduce the incidence of cancer. So now coming to last part of my talk is about lifestyle. Your occupation has a lot to do with your lifestyle, and sedentary work is a very important risk factor. I don't know how many of you have a sedentary lifestyle and how many of you have active lifestyle, but how not having an active lifestyle can increase risk of certain cancer. I'll just talk about that. So I'll talk about two common cancer, that is breast and endometrium. એટલે સ્તન અને ગર્ભાશયનું કેન્સર, આ બે કેન્સરને અમે લોકો લાઇફસ્ટાઇલ કેન્સર કહીએ કે આના થવાના કારણ મેજરલી લાઇફસ્ટાઇલ છે. આ અર્બન કેન્સર છે, વેસ્ટર્ન કેન્સર છે. એટલે એક જમાના પહેલાં we had a very low incidence of this cancer, but in last 30-40 years we are seeing looking at an epidemic of these lifestyle cancers. So is cancer a lifestyle disease? Again there is a question about it. Cancer તો કોઈને થાય, એમાં લાઇફસ્ટાઇલ સારી હોય તો એ થાય, ખરાબ હોય તો એ થાય. But is it lifestyle disease? See, there is a great difference of incidence of breast cancer in developed and developing nation. એટલે આજની તારીખમાં યુએસમાં ઇન્ડિયા કરતાં 3 times more incidence of breast cancer છે. યુકેમાં પણ probably 3 to 4 times more incidence of breast cancer છે. હવે ડોટર્સ ઓફ એશિયન ઓરિજિન જે ઇન્ડિયન ડોટર મેરેજ કરીને અમેરિકા જાય છે, તો એનું જો રિસ્ક ટુ હેવ બ્રેસ્ટ કેન્સર ઇઝ ઓફ યુએસએ એન્ડ નોટ ઇન્ડિયા. એટલે એનો લાઇફસ્ટાઇલ અમેરિકન થઈ ગયું તો એનું રિસ્ક પણ વધી જતું હોય છે. એન્ડ વી આર સીઈંગ સ્ટડી ઇન્ક્રીઝિંગ ઇન ઇન્સિડન્સ ઓફ બ્રેસ્ટ કેન્સર because of adoption of Western lifestyle. That is why we say that it is a lifestyle cancer. And what are the lifestyle related factors? Obesity, smoking, shift work, healthy diet, physical inactivity, diabetes and stress. So overweight and obesity, अपना त्या prevalence of obesity is approximately 35% 2017 અને એ વધી રહ્યું છે. અમે પણ હોસ્પિટલમાં જોઈએ છે કે we see more and more obese people coming for treatment than what we used to see 10 years back. And obesity counts for almost 25 to 35% of major cancers. So very obese people have a significant high incidence of breast and endometrial cancer as they are directly related with obesity. And કોઈ વ્યક્તિ જો weight loss કરે તો એનું incidence, એનું risk પાછું normal થઈ જતું હોય છે. That is important to know. Women who gains weight during adulthood doubles their risk, and if she loses weight, then her risk come down significantly. Physical inactivity is again obesity એક જુદો risk factor છે. Inactivity એટલે કોઈ physical exercise ના કરવી is another important risk factor for this lifestyle cancers. Physical activity પણ measure કરી શકાય. Like 1 hour of moderate walk is metabolic equivalent of 3. So there is positive correlation between intensity of physical activity and risk reduction. So with every increasing physical activity, one can certainly reduce chances of suffering from cancer by significant percentage. And benefits are seen in elderly more often than younger. In short, there is strong correlation between physical activity and inactivity with breast cancer. Even walking 2 to 3 hours per week reduces risk significantly. So there are multiple studies which have shown that simple walking, like instead of taking lift you take stairs, instead of taking bike you walk down to your work, even this small activity reduces chances of suffering from lifestyle cancer like breast and endometrium. Reduction in risk were also observed by doing household activity, walking for transportation. જરૂરી નથી કે તમે જીમ જાઓ કે રોજ 3 કિલોમીટર જોગિંગ કરો. તો સિમ્પલ એક્ટિવિટી જે ડે ટુ ડે લાઈફમાં આપણે કરતા હોઈએ છીએ એ પણ રેગ્યુલરલી કરો તો એનાથી પણ કેન્સરનું રિસ્ક ઘટતું હોય છે. Dietary factors are important. it is a myth that non-vegetarian food can cause more cancer, but red meat is kind of important etiology for colon cancer. And poultry and fish have a protective effect on human body for cancers. Again, treatment of diabetes is equally important if somebody is suffering from, because chronic diabetes can also lead to some few types of cancers. The treatment of underlying insulin resistance in type 2 diabetes is important to prevent further risk of cancer. So what lifestyle strategies is simple and easy to remember? That one should have a diet rich in fiber, fruit and veggies. Body mass index should be checked between 20 and 25. Exercise regularly. Limit red meat and abstain from alcohol and smoking. And to conclude, occupational, environment and lifestyle factors are pretty common cause for cancer, and 75% of cancers are attributed to them. De-addiction of family, friend, workers can be a very important strategy which can be implemented immediately in industry for a health workforce. And lifestyle does help. Physical activity, doing exercise on regularly does help. Thank you.
Yeah, thank you so much. There has been some change in the schedule, and we are going to keep you hungry for another half an hour, right? May I request the chair to honor our speaker with token appreciation? Requesting Chairman of Scientific Committee to present memento to chairpersons.
Good afternoon, everyone. I will now request our chairpersons for the next session, Dr. Kishore Parekh and Dr. Samir Chaudhary, to come on stage, please. Dr. Kishore Parekh is the former president IAOH and Central Council member IAOH since 2005. And Dr. Samir Chaudhary is the Global Health Specialist, Hitachi Energy Limited, with an experience of 10 years. I welcome you both. I would now hand over the stage to the chairs to invite the speaker for the next session. Thank you.
Good afternoon, everyone. We welcome you, GUJCON-2022. Today, we have very eminent personality between us, Mr. Yashwant Singh D. Pawar. It's my privilege to chair this session because I also spent many years with him. He is also my teacher. He has taught me many things in HR. Because when we enter in any industry, we are just doctors only, but we have to learn from HR, safety, and all plant head and everybody. So now, it's my pleasure to introduce Mr. Yash Pawar. Mr. Yash Pawar did his post-graduation in HR coupled with degree in law and deep in HRD at community development. He has 45 years plus experience of having worked with MNCs and Indian companies of repute as VP and head HR with Atul Products, Apollo Tiles, Alembic, Safari Industries, Flint Group, Searle Group, Steel Tubes, Thermis Group, Cyanides and Chemicals, Mapatlar Groups. So he has vast experience in the industry. Since last 10 years, he has been working as a consultant, trainer, mentor, legal experts, and organizational development strategist with couple of reputed MNCs and Indian companies. He has twice represented as Indian delegates on OSAs and CSR in ILO, that is International Labour Organization. He also represented a National Commission on Labour as well as Labour Reforms committees in All India Employers Organization, CII, Gujarat Employers Organization, and before the government of Gujarat. He had been secretary and executive committee members of Industrial Association and continued to be governing body members of Gujarat Employers Organization and executive committee member of All Indian Employers Organization. He had traveled to 11 European and Asian countries on TQM, safety and manufacturing excellence related to training and conferences. He had been faculty to MS University, Parul University, chairperson of Syllabus Committee of Gujarat Technical University and Nirma University. In short, we have very versatile, dynamic and very well-experienced personality between us. Let us have his experience sharing with us. We invite Mr. Yash Pawar. Mr. Yash Pawar, please.
I'll just begin with the presentation. Okay, so good afternoon, friends, and thanks to the organizing committee and Hotel Sayaji for keeping my session before the lunch. So I feel myself privileged. Otherwise, after lunch, there is always a tranquilizing effect. So nevertheless, it is on the lighter side. So friends, I'll be sharing with you, I'm not a technical expert, but yes, all along my career, safety, health and environment was part of my assignment. And as a team, we were working on that. So something what I have learned and some practical tips which I would like to give you, particularly for the HR team, HR member, HR professional, HR fraternity, that what is expected from them in terms of EHS and what should be their deliverables, and later on many things it will follow. So it's basically an experience sharing, not a technical paper I am presenting. Nowadays when you open the TV news channel, you first thing find people saying that ये देश संविधान से चलता है. So I thought it is my moral duty to repeat that here, that under the Constitution, article number 2439, into bracket ENF and 42 provides for protection of safety and health of employees, men and women. It further advocates provision for just and human conditions of work and maternity relief to the workforce. This is basically provided in our constitution, which is one of the finest piece of constitution in the world. Now today we all have assembled here. We have so many experts from the medical, so many from the SHE profession and from HR profession and other experts. The need is very dire, really very dire. And we must appreciate that down the line what all has happened and why this is being insisted upon time and again. I would briefly say that now it is all the more reason for India because we are becoming a very respectable community in the global world and manufacturing hub for many things. So India is a country now scaling up to newer and newer heights in every walk of life and more so towards becoming a global manufacturing hub for variety of products. In this mad race of industrialization, a lot of compromises are being made in the quality of life and health and for safe living. Occupational hazards and risks are recognized to be more widespread in SMEs than in large enterprise, and attention on unorganized sector is totally missing, which employs more than 85% of workforce. This is very alarming and attentive situation where so far nothing visible, nothing important, nothing significant has been done for the unorganized sector workforce and for the SMEs. A lot of compromises are being made, and even law enforcing is also not all that effective. Now, statistical data reveals that some of the cities like Kanpur, Bhiwadi, Delhi, Ahmedabad, Ghaziabad, Vapi, Ankleshwar, and many more to add the list, are having a very alarming level of pollution, which adversely affect the quality of health and society by and large. So these are the facts which we cannot ignore. More than 80% accidents happen due to unsafe acts than that of unsafe conditions. Many researches have been done and it has been revealed that major cause is our mindset, our aptitude, our behavior, our overconfidence. So unsafe conditions of course contributes to the unsafe conditions, but the unsafe behavior, unsafe acts are rather more responsible. Lack of creating awareness and providing training and its impact analysis. Training has become a ritual. Training has become a matter of calendar. Training has become a part of KRA. But impact analysis, what is really needed to be done, has rarely been done. Counting very few industries, those who do the impact analysis, and even I would go to the extent of ROI of training. Very few companies have this mechanism in place. Laws framed are not effectively implemented and are not comprehensively covering unorganized sector in a structured way. This I have already told you that unorganized sector is a very vulnerable sector. Laws are very nicely made, very nicely enacted, but point is that government machinery itself also has certain compulsions. The kind of staff they need is not there. Today we can see in our labor department how many officers, commissioners, inspectors are missing, and the kind of industry coverage they have been given, which is physically not possible. Not possible, even if 24 hours that fellow works, he will not be able to cover organized and unorganized sector both. So that is our somehow unfortunate part of the things. Effective infrastructure framework is miserably missing for elimination of air, water and noise pollution. Pace and adoption of green technology is below the level of other countries. You go to the European countries, I have traveled a lot and I have seen the adoption on the green technology, the level, the degree is very high. In our country, safety is considered as an investment, not as an investment, and it is considered as a last priority item as far as investment is concerned. So green technology is demand of the day, which we must think of to reduce the elimination of all sort of pollutants and to reduce the accidents happening in the companies. And ultimately, All the above factors are adding to n number of occupational diseases and overall condition of health and safety. You will appreciate with this given situation what will be our quality of life. Now coming to the HR role and responsibility, in many organizations by and large, somehow EHS department has been associated, has been reporting to HR. HR is neither a medical professional nor a technical professional. HR is a humanities and it's a social science. But still, there must be something. That's how it has been thought fit that it should report to the HR. But that is not the line of control. HR is also reporting to the technical departments, unit head. So I am not going into the matrix of reporting, but the point is that HR has to play a great role, and HR has a great responsibility even if safety, health and environment is not reporting to HR. We call it in short form SHE, S-H-E, and SHE is a feminine word. Now feminine word itself has a lot of tenderness in their behavior and in their aptitude and in their appearance. So I always say that SHE is a feminine word, and feminine, the first feminine come to our mind is a person who has given us a birth, and that is mother. So she has an indication with the mother, relationship with the mother. So what is the role of a SHE and HR? A SHE has a love, affection and care, and that is what is expected from the HR. As a role of a mother, HR should play. Cultivating and nurturing sanskar as a teacher, which mother teaches us till we are grown up. So entire thing of what we call it a sanskar comes from the mother first. Mother is the first teacher. Then encouraging and promoting cultural values as a mentor. She is our mentor also. She holds our hand and tells us what are do's and don'ts. Scolding on wrong things and unsafe acts, and imbibing discipline and do's and don'ts as a monitor. We have been seeing that, we have witnessed that in our childhood, that how we were scolded, how do's and don'ts were taught to us by our mother. So, in creating a safe and happy way of living together, HR has a great role as an enabler to this profession and to this very subject. Now, point comes that how HR can add value as an enabler. So obviously the question will come to everybody's mind that what is expected from HR? You see, the question is that what is expected? What are the deliverables which are expected from the HR in terms of their, in terms of SHE management? And what skill set HR should have to attain these objectives? Certainly for any profession, anything you need is some set of, skill set to achieve your goals. And how it will be achieved? The big question is that how it would be achieved. And how, even after you achieve, how on a sustainable and renewal basis you will continue to do it. And how the culture of safety to be built in collaborative and team spirit with a sense of responsibility and accountability. This is what is the role of HR, in short, is as a custodian of HR. Because human resources working with you are the major assets and the bigger assets and valuable assets than that of plant and machinery. So HR has a very important role on their shoulders to carry as an enabler, and what they are expected to do, I'll be coming to that question. Who are our stakeholders? Obviously, when we are working in industry, there is employees, workmen, and their families. They all are our stakeholders in the whole process of maintaining a good safety and environment and health standards. Shareholders, obviously, because their money, financial institutions, their money is invested in your industry. They are your shareholders. And customers and suppliers, those who are dealing with your business, their survival also depends on your profitable and sustainable business, running of profitable and sustainable business. So these are our major stakeholders. But I will go one step ahead, that society at large is also our stakeholder. Reason being the pollution which goes out in the air and water. And second thing, what are we going to leave for the next generation? The point is that today in whatever condition we are, okay, fine. And the way things are happening, what will be the condition of quality of life? Are we going to provide them, next generation, a better quality of life, healthy quality of life, or the same polluted quality of life and adulterated quality of life with the lots of accidents and lots of unsafe things happening and lots of nonsense happening in the whole scenario? So, I would say it's a major responsibility for each of us, those who are associated with EHS, and more particularly for the HR. This they have to ensure. Now, in short, what these stakeholders expect, very simple. There are no major things. They only want, in one sentence, safe, happy, and healthy life, with good amount of return on their investment and work performed by them for a better future. People spend their 70% of life in your industry, in your organization. What they expect? Better quality life, better safe life, and happy life at the end of the day. Now, skills and knowledge, what HR should have. There is a big myth in the minds of people that they are confined, HR professionals are confined to, training, recruitment, PMS, engagement, and compliance, and blah, blah. Fine, that is also part of the job. But they never think that if safety, health, and environment is reporting to them or does not report to them, doesn't matter at all. But as a moral responsibility of the profession, what they should know, ultimately knowing some subject is not a rocket science. So we should not be with a compartmental thinking that since I am a lawyer, since I am a HR practitioner, since I am an accountant, I should not, or I am not expected to know anything pertaining to safety, anything pertaining to environment or medical science. It's not like that. I tell you my own experience. I'm not boasting about myself, but when I talk to doctors, when my relative or some friend is admitted, and the dialogue which happens with the doctor obviously asks me at the end, are you a medical professional? I said, no. Then in paramedical, I said, no. So thing is that I have interest. Dr. Kishore knows how many times I used to eat his brain. It's my curiosity, it's my interest, it's my profession. I must know. If I am in HR, human resources are affected by many things, So basic knowledge, at least, of medical science and toxicology, what is carcinogenic agents, what are the toxins, what toxins has, what side effects, what antidotes should be there for what. If this is there, the HR would be more effective in performance its duty towards the EHS. So I always say the knowledge of legislation dealing with safety, health, and environment, obviously HR should have, but primary knowledge of medical science, toxicology, and first aid should also be there. I am not telling them to become a master of that, but primary knowledge they must know. They would be in a better position to appreciate the things, to analyze the thing, and to address the issues in a right frame of mind. Effective listening and networking for getting support and advice. Now, there are many governmental and non-governmental agencies, those who provide lot of support activities to the industry. How many of us are seriously taking help of them? You go to their sites and see what all supports they are providing. To name them few, that is DGFA-SLI, then Factories Inspectorate, OSH related institutes, then National Institute of Occupational Health, National Institute of Construction Management and Research, ASK, Association for Stimulating Know-how, NBCC, National Building Construction Corporation, Director Labor Welfare, and National and Gujarat Safety Council. These are couple of important institutions, governmental and non-governmental, I have pointed out there. if you really go approach them, ask them, you will get wonderful support and wonderful activities they are doing for the sake of safety, environment, and the health. And many activities they have, and a number of things. You just contact them, go to the sites, visit them, you will come to know. Make use of this. Government has given everything, but it is up to us to avail those facilities and avail the benefits of the schemes they are providing. Now, what are the major issues and concerns today if we ask on the SHE or ESH? Basically, migration, degree of migration from rural to urban area is happening. And urban areas, more and more employment opportunities are available. So the people coming from the rural background, the migrant workmen from the rural background and rural, mindset, they are coming, they are inexperienced, they do not know industrial culture, forget about the safety, but even otherwise. And we, by and large, in most of the industries, our dependability is very, very high on contract labor. And when we talk about contract labor, you will find people, of course, now since last 2-3 years, the migration from UP, Bihar and Assam and Orissa has reduced because a lot of employment opportunities are increasing there. But you look at the prior scenario, people used to migrate to Gujarat and Maharashtra mostly. So they are not, cultured as far as industry and safety culture is concerned. I would say they are not cultured from that orientation point of view. Top of that, again, our GDP, our economy, our dependability of the whole economy lies with the SMEs, which are major contributors in the GDP and major employment providers also. Now, how SMEs are taking seriously, you tell me, because I know, I have seen, I have visited, interacted, and many platforms we shared the views. Short of very lukewarm response to our EHS. They take the things for granted, कि ये तो चलता है, इसमें कोई ऐसी बड़ी बात नहीं है. But जब होता है, then they realize and then they rush for the anticipatory bail to high courts. But SMEs have this tendency, you can't help it. It's not only EHS, even for the compliance of all other laws, other labor laws also. That is most unfortunate part. But this is the issue today, and this is the area of concern for all of us, including government, to think what should be done to make it more effective mechanism towards more effectiveness. Lack of proper mechanized material handling equipments. Again, since labor is cheap, give them minimum wages, hire them, get the things done manually, and those manual things attracts a lot of industrial accidents. A lot of accidents which affects the limbs of the people, those who are handling material. There are good material handling equipments available, but that is somehow happening. Lack of collective bargaining, power to insist on EHS issues. This point I'll take at the last because it has certain practical issues connected with. No permanent record of workmen in an unorganized sector is available, which deprives them of social security benefits. Because unorganized है, कुछ भी चीज organized नहीं है. ना तो they are system driven, not they are professionally driven, and nor they are record driven. Record तो they are very scared about keeping the records के कल उठ के किसी ने पकड़ दिया तो मर जाएंगे. इसलिए record रखो ही मत. Sizable numbers workers I have already covered. Another thing, consumption of alcohol and tobacco. Though we have a policy, we have a system, but still somehow it is happening. Even in pharmaceutical industries, I have seen where GMP is at the highest importance level, but they have innovative ideas somehow. How they carry this tobacco and how this pan padiki business continues in the industry and how does it affect the customers and the quality of your product, we all are aware. But it has to be made more strict. It has to be innovatively, like the worker is thinking of bringing that in. We should also have some innovative ideas to trace these things. Seriousness of both the parties is not enough and overconfidence prevails. As I told you, worker is also overconfident that this I have been doing since years, since ages. Nothing has happened. He is used to it. But one fine morning, not fine morning, but a bad morning for him, that some such accident happens. and either he loses his limb or he loses his life. So workers have a tendency. That is why, behavior-based safety comes. And that is why people say that and research say that more accidents are happening because of unsafe acts. Why unsafe acts? Because workers are confident of doing things in a particular way. Nothing has happened, so nothing will happen also. There was a Sardarji joke that his right hand came into the machine. He immediately took out the right hand and put the left hand inside. So one fellow asked him that, "Arey, kya hua? तुम्हारे को left ये injury कैसे हो गई?" तो सरदार जी से, "अरे मेरा वो right hand अंदर जा रहा था जिससे मैं काम करता था, उसको निकाल लिया, दूसरा डाल दिया." तो this kind of overconfidence people have. So seriousness is required from both the parties to take safety, occupational health, and overall environment very seriously. Otherwise, we never know where the things will end up at last. Now the question comes, how the journey should start. Now, it's a journey from protection to prevention. See, protection, you have provided PPs, you have systems, fine, all that good. You have permit systems, fine, all that good. But the journey doesn't stop here. You have to be continuously on the prevention side, So for preventing, for making it a proactive action toward the EHS, what you need to do is increase awareness and sensitize on the importance of OSH. Create and foster a safety culture. It should be a culture which means that you walk the talk. I know in one of the organizations where I was working, my executive director used to take plant round with me, and during the round, if he sees anything which is unsafe happening, whether it is a condition or an act, or a particular thing lying in a particular way, he used to immediately point out, immediately call that department head, immediately call that person. Even Pan Padi ki that packet, if it is found on the floor, he himself will lift that and keep it in his pocket. The next stage he went up to this, that when I take a plant round with HR head, and if I find anything which is unsafe, or anything which is against 5S, or anything which is unhygienic, that day I will not take lunch in the canteen. And our canteen was common. Worker and staff, we all used to take, including managing director. And literally he did like that. Number of times he didn't take lunch in the canteen. So what I mean, it was giving a psychological message to the workmen कि जो हमें रोजी दे रहा है, वो ही रोटी नहीं खा रहा है, तो ये तो अच्छी बात नहीं है. And there HR also played a lot of contributory role in creating that awareness. And ultimately situation came to that level that he had never found such situation that he had not to take lunch on that particular day. So this is called walk the talk. You have nice safety policy. You have copied from DuPont and some other good companies. You have some practices also in place. But again, we are not walking the talk. We are seeing and ignoring. Sometimes we attend, sometimes we don't attend. So that's not correct. So we should walk the talk. Introduce behavior-based safety instead of result-based safety. What happens today in most of the companies, they see the results and then they come to the solutions, which is called a result-based safety. That's not right. Let us be adopting now, which most of the companies are doing, professionally advanced companies towards the behavior-based safety, and which really gives good results. Because there it is observation-based, there it is possibilities-based, there it is situation-based. It is not on the result-based. Encouraging participation workmen through quality circles, Kaizen, and small improvement plans, because they are the person, those who are going to be affected after all. Involve them, listen to their suggestions, involve them on different platforms, reward them. Another unique thing I tell you, which we practice in Apollo Tires, we had, every manager had KRA on safety, and that KRA used to carry weight. There was a weightage given, and KRA, one of the KRA was on safety, health and environment. you can imagine the importance and seriousness management had given to this. So this should also be one of the KRA for all the managers, that how they are developing, how they are recognizing, how they are appreciating, how they are rewarding, and how they are involving people. So how much inclusion is there in the EHS management? Educate training and evaluate training, again, as I told you, evaluate, do the impact analysis, even do the return of investment also. To that extent one should go. Create system for reward and recognition for the good work done on OSH through suggestion scheme, through Kaizens, through near-miss reporting, competitions, trophies. There are many, many things which one can always, as a HR profession, they can introduce participative culture for promoting the safety. Participate in Vishwakarma, Rashtriya Puruskar, Prime Minister and Sharma Award, NSC and GSC awards, National Safety Council, Gujarat Safety Council, they have awards. Participate in them, motivate your people to work on that, take part in that. Working environment monitoring and health surveillance of workers exposed to physical, chemical or biological hazards. Nowadays we talk about biological hazards also, which was before a decade or so was not that much importance, but now today we talk about biological hazards also. So we should monitor that even, and we need to address new emerging psychological hazards. Now, work from home, working on the computer constantly creates lot many ergonomics and musculoskeletal related disorders, which I don't think by and large anybody has addressed to this at a workplace. But it is a fact. Working on computer throughout the day, sitting in a particular position, these all creates ergonomics issues. But that is also a working hazard, I would say. Now it is also called a hazard. So we need to address, we need to advocate, we need to evolve such strategies and initiatives which can eliminate ergonomics and musculoskeletal related disorders of the human body. There are insurance schemes for occupational accident and diseases, which I am sure you must be aware, and avail that if not availed so far. Define responsibility at each level and do partnering with shop floor workmen with due empowerment. Now when I talk about empowerment, it's again another gray area which is not there in our companies, in our industrial setups. I had been to Japan, I saw a fellow worker on a particular process was empowered. If he finds any deviation on quality or any deviation in safety or anything which he finds is not correct, he can raise the flag and he can stop the line. That is called a real sense of empowerment, which today even department head or production manager doesn't have. Forget about worker. And there you see the culture. Worker was empowered to stop the production and nobody will ask him, because he has a reason to say. If he sees any near-miss thing happening or not attended, he has a reason to stop. So that kind of culture, that kind of proactiveness, that kind of empowerment, we all should be given so that we lead a better, safe life. Monitor, analyze and evaluate incidences through an improved data collection by its severance. Pareto, see the frequency of that, analyze that, root cause analysis, kappa, hazard, impact, all that I think most of us are doing. Then introduce Pokayoke. Pokayoke is the system which I said, okay, you can stop the thing where you find the things are wrong. This is again a Japanese practice. So same thing should happen for safety. It is not only for quality, it is for safety as well. Have toolbox meeting and plant route every day, which is of course a very common thing. We have a safety committee in our organization everywhere. Have section-wise also safety committees. They should also meet so that issues are addressed faster and they should not wait for the apex committee to address and discuss the things. A strong presence of visual management should be there. Have a rigorous follow-up and develop dashboard system, which is again very good thing to follow,
sir,
to monitor, to evaluate.
5 minutes more, sir, please.
2 minutes. Then,
sir, please conclude within 2-3 minutes.
Sure. This is last point. I think this is last slide, I believe. Yeah. Now, the thing is flip side of the EHS. So far, we talked about proactive, we talked about preventive, we talked about need of the hour, what is the role and responsibility, how we should have our forward journey. Now, I tell you, the flip side of the EHS is that in most of the organizations where there is a multiplicity of unions, or there are, kind of unions which are unions, by all means. I should not define good or bad unions. But they create some such issues unnecessarily, for their vested interest, for their comfort. And I must put it on record here that in Apollo Tyres, this was a big issue with us. Dr. Ujjwal and me, we were the team on EHS. And kind of dramatics, the kind of scene they will create, the kind of situation they will create in front of you, you will fall in that trap, literally. And the number of days lost because of these kind of reasons, so-called accidents, so-called fabricated accidents, so-called sham accidents, were tremendous. And I must appreciate Dr. Kishore, and it was his KRA also, to reduce the man days lost in first quarter itself by 50%. And he overcrossed 50%. The reason being, he was constantly following up, even to the extent, odd hours he will go to the hospitals and home visits also, to ensure that genuineness. People are comfortably okay. The moment they enter in the gate, they will start trembling like this. Kya hua re, kal saab gir gaya. There were people, you won't believe, so brave soldiers. They will cut their some, thing, either hand or finger or somewhere, because vacations are approaching. So they have to go to UP, Bihar, Haryana and all. तो अभी वो छुट्टियां तो सब खत्म हो गई हैं. तो accident leave मिलेगी, paid leave मिलेगी, कोई पूछने वाला है नहीं. And this was the trend, which all of us together broke that. So वाह छुट्टी हो गई, डॉक्टर के पास आएंगे, साहब एक्सीडेंट हो गया, छुट्टी, घर पे बैठूंगा, क्या करूंगा. हमने वो भी बंद किया. And then doctor came out with the idea, okay, let us call them at the workplace. Let them sit there. We give them some or the other job. So light duty देना चालू किया. अब light duty भी एक disease हो गया हमारे लिए. Because then everybody was asking about the light duty. So anyway, very smartly, with his intervention and his dedication and the kind of innovative ideas we worked out, we could, stop that nonsense, and accident man days loss reduced to a great extent. Because these things happen. Workers make safety sometimes abuse. Workers make it a point of their comfort to encash it this way or that way. And you won't be believe, accident आज हुआ है, आज से accident लीग की शुरुआत होनी चाहिए. हमने रेलवे रिजर्वेशन ऑफिस में जाके मालूम किया, उसने 30 दिन पहले बिहार का रिजर्वेशन करा के रखा था. So accidents were forecasted. We said prevented, but they were forecasted. So this is something very naked truth of industry which happens. So there the role of EHS and HR comes, that they should be very vigilant, very smart, and very attentive on such things. And to large extent, with the help of Dr. Kishore Parikh and Ujjwal also, we could reduce that to a great extent. Now this is flip side. Now another thing I tell you, many of us have unions in our organizations. They always, every third or fourth year, come with their big list of charter demand, not less than 50 to 60,000 rupees rise per month they ask. But none of the union has ever asked about better service conditions, better working conditions, sorry. I came across one company in Thane Belapur Road, where the charter of demand of the union, the first demand was for better working condition. So that is called the power of bargaining. When you are united and when you are collectively bargaining with the management, unions also have a role to play for their workers, for their followers, for their members, to request the management to provide better and safe and healthy conditions, which is not happening, unfortunately. So friends, this was the presentation and an experience sharing, I would say. And I'm thankful to you. Thank you.
Thank you, Pawar sir. You highlighted many things on HR. You know HR's multidisciplinary role in the industry. So they are really enabler for the safety, health and environment. So and particular where the IR issues are more than myself, himself, the lot example of experience sharing. So it was very well knowledge sharing experience by Mr. Pawar. Thank you so much. Yeah.
Thank you very much, sir, for this very interesting session. I request Dr. Kishore Parekh and Dr. P.C. Jain, sir, Chairperson GUJCON-2022, to please come on dais and extend a token of appreciation to Mr. Yash Pawar.
P.C. Jain, sir.
Thank you so much, sir. I now request Dr. Milan Thakur, Secretary, IOH Vadodara, to please come on stage, please.
Thank you all delegates. I, Dr. Milan Thakur, Secretary on behalf of IOH Vadodara. Thank you all of you for coming over here, sparing your valuable time. And I regret for inconveniences, if any, at the start of the program, because we had a high number of delegates, more than expected, more than 50% of the expected population we had today. And I thank all our sponsors, platinum sponsors, Bailal Amin Hospital, Opti Surgicare, Reliance Industries, Sterling Hospitals, Tricolor Hospitals, Unity Hospitals, Zydus Hospitals. Our gold sponsors, BAPS Hospital, HCG Cancer Hospital, L&T India, Rhythm Heart Hospital, Sunshine Global Hospitals, Shriji Hospital Chani, UPL Limited, and our silver sponsor Aditya Birla Group, and our digital sponsor Cipla. I now request all of you delegates to proceed for lunch and have a good time. Thank you.
Everyone, in the post-lunch session, we shall be continuing with the previous sessions chaired by Dr. Kishore Parekh and Dr. Sameer Chaudhary. I request Dr. Sameer to take on for the next session and chair introduction.
Thank you. Good afternoon, ladies and gentlemen. Our next topic is on cognitive interventions to enhance health and safety. And we have with us Mr. Milind Ranade, who is loss prevention specialist and risk consultant. He has Bachelor's of Engineering and Post-Diploma in Industrial Safety. He is a certified chartered engineer, competent person as per DISH, and fire safety officer. Milind started his career as project engineer in Hindalco and has had professional experience of over 20 years since then. His last professional assignment being Vice President, Marsh Risk Consulting. He has also worked with Cholamandalam MS Risk Consulting Services as General Manager. And with several years of experience, Milind is passionate trainer and student of human behavior. He has been intrigued by the way same humans behave under different situations differently. This has led him to taking up the subject of cognitive neuroscience to enhance safe behavior at workplace. I welcome you, Mr. Milind Ranade, on behalf of IAOH, please.
Good afternoon. Good afternoon. જમી લીધું બધાએ? હવે ઊંઘવાની તૈયારી? સો આ સૌથી ટફ સેશન હોય છે. જેટલા લોકો લંચ પછી જેટલા લોકોએ બી સેશન લીધા હશે, they all might know this is one of the toughest times to keep people awake after such a heavy and sumptuous lunch that you have had. So as doctor introduced, today is Saturday, and this is my Saturday, Sunday is a day when generally I don't work. So this is something which I devote for my passion. And talking or training people and understanding human behavior is my passion. So things which he read about me are things which I do from Monday to Friday. Saturday, Sunday, generally I tend to relax and tend to devote time to something which I love. So to start off, all of you today have gone through a part of social experiment. I would cover that once we start the session. And this would not be a typical session where I would continue talking. I would seek interventions or responses from you continuously during the session. So are you awake? And the difference is I am not going to ask you to raise your hand, but I am going to choose who is going to speak. So you need to be awake. Okay. How many people sitting here think they are unbiased? Biased? Unbiased. How many are unbiased? Okay. So many people say they are unbiased. So what is bias? Does anybody understand? Everybody understands or have heard the word biased, right? But do you know which is the most common bias term that we hear or we use? Sorry? Influence? A very common bias which we all talk of. Huh? Color bias. Okay, ma'am says color bias. Gender bias. Right? Okay, so let's move with the session. I think all of you who have come here today must have had these questions since morning. But let me just introduce to, I think most of the doctors would understand what is cognitive. But to my other friends who are from the field of safety, they also, most of them now understand this subject or the topic. It's a mental process or process of thinking, the way decisions are taken or the way a reason is given for any decision that you take, right? So I think everybody today morning had an issue with what to wear, right? Everybody? Maybe few people from the organizing committee, they knew this is what they are going to wear. But beyond that, everybody else, you had a choice to make in the morning, right? What to eat? Today we had a very good menu. 3 શાક હતા. પછી ગુલાબ જાંબુ બી હતા અને આઈસ્ક્રીમ બી હતું. So who had gulab jambu as well as ice cream both? Oh, quite a few. Okay. પછી સવારે જ્યારે અહીંયા આયા, when you came here, you had an option. People who came in the first 10, 15, 20 minutes, you had an option where to sit, right? Somebody decided to sit, thought, okay, पहला रो बाकी रखते हैं, second रो में बैठते हैं. कुछ सोचा चलो थोड़ा पीछे बैठेंगे, वहाँ से बाहर निकलने में easy होगा. हाँ? So you had a choice. Maybe few people who came late, they didn't have a choice. उनको तो क्या देखा किधर जगह मिला उधर जाके बैठ जाते हैं. But most of the people who came early had choice to make. So life is full of choices, and all the outcomes that we see today or we face today are a result of conscious or subconscious choices that we have had. To maybe make the session a bit lively, somebody, I need a volunteer who would tell me which phone they bought. Who bought a phone very recently? Somebody bought a phone yesterday? New smartphone, who bought it yesterday? Anybody? In this week? Somebody who bought a phone in this week? Somebody who bought a car this week? Nobody? Somebody who bought a car or a phone this month? अरे बहु मुहूर्त था यार, कोई तो लीधी हसे कि नहीं? Ah, okay, there's a lady who has. What did you buy, ma'am? You got a car? Which car did you buy? Okay, she bought a Tata Punch. I hope you don't mind taking your example. No problem. Okay, she's agreed to be my subject right now. So there were list of, you had your requirements clear. Then you might have surveyed a lot of options available in the market. There was a budget. So you overshot your budget, or it was within the budget? Okay, she is a good buyer. She has not shot her budget, or she might have had a decent budget to manage her latest shopping into that. But generally what happens is our subconscious mind actually takes the decision, and our conscious mind justifies that decision. How many people would agree to this question? What is the statement? Subconscious mind takes the decision, and the conscious mind would give all the reasons to justify that particular decision. Okay? So why this color, why this shirt, why this jacket, whatever it is. But consciously you try to give all the reasons to justify your decision. But the decision is actually made at the back end, at the subconscious level. What happens? So when we are talking here, I am not going to deliver more on general, but the discussion has to be focused about occupational health and safety. So occupational health is the health that I think we heard speakers in the morning talking about the legal requirement for occupational health, what all can be the issues with occupational health. I want to give a slightly different thought process to looking at this entire subject. So maybe just to tell you, incidents are the outcome of choices that went wrong. As I said, anything good that happens because a good choice that you did. And all of you read about a bus accident in MP 3 days back. There was a bus from Maharashtra State Road Transport Corporation which fell into the river Narmada. Does anybody know what was the root cause for that accident? Has somebody read about it? Anybody? Okay, doctor says, no, it's not what you say, you have read it. I have also read the same thing in the newspaper and the news anchors, what they said. It was the driver of the bus was trying to save a two-wheeler driver who was coming from the wrong side. This is what I have read. So, quote unquote, I have read this and I am quoting this here. So on that basis, somebody who knows me and is my friend on Facebook, I posted this as a different way of thinking. The accident was a cause of a wrong side driving by a two-wheeler driver. In pursuit of saving the two-wheeler driver, the bus driver had to take a cut. While doing that, he could not manage or could not control the bus, and the bus fell into the river. Almost 15 or more than 15 people died in that. But the two people who were coming from the wrong side were saved. Now, who was at fault? Ideally, the way of thinking, the choice that the bus driver did take was trying to save the two-wheeler. But imagine the guys were from driving on a wrong side. So just a scenario where the bus driver would have not taken this action and he would have hit the two-wheeler. The worst scenario would have been both the two-wheeler driver as the pillion, the passenger, would have succumbed due to that accident. In that, just a thought, in that case, people would have crucified the bus driver. बड़ी गाड़ी वाला लॉजिक चलता है ना, वही चलता है ना, राइट और रॉन्ग तो होता ही नहीं है, जिसकी बड़ी गाड़ी उसका फॉल्ट है. This is the rule of the jungle, right? Or rule of the traffic that we follow. Bias, I would say. Gender bias तो हाँ, उसमें gender आ गया तो फिर gender bias भी है. तो वो एक अलग कॉम्प्लेक्स सिचुएशन हो जाता है, राइट? अब बड़ी गाड़ी वाली लेडी है तो हो सकता है कुछ और ही टर्न होगा इवेंट्स का. बट एनीवे, इट्स अ मैटर ऑफ चॉइस. द एक्सीडेंट विच हैड हैपेंड बिकॉज ऑफ द right or a wrong choice. See, the driver might have had fraction of a second to take a call. So आज इधर बैठ के जितना मैं एनालिसिस कर रहा हूँ उसको ठोक दिया होता तो भी चल जाता, लेकिन 15 पैसेंजर तो बच जाते थे. So all those things we can talk retrospectively sitting here in a air cooled room with all the data available at our hands. एक ऐसा सिनेरियो या एक ऐसा एक्सीडेंट जो हुआ था, मेरे पहले उज्ज्वल ने भी आई थिंक रेफर किया, द इंसिडेंट विच हैपेंड एट यशस्वी. And I am quoting this because now the case is in public domain. Otherwise, I would have refrained from quoting any names. But it was a classic case where, if everybody knows, obviously the officer sitting here would definitely know what was the case. In एक दिन पहले से केस चालू हो गया था. There were wrong chemicals which were mixed, and then the process of taking those chemicals out was going on. And that is the time when the entire accident happened or the incident happened. So एक छोटा चीज़ बचाने के चक्कर में बहुत बड़ा इंसिडेंस हमने. See, again, the people who did it might not have thought कि ये इतना बड़ा convert हो जाएगा. So this is all what I say about incidents. एक World War II का incidents मुझे याद आता है. Somewhere I read. So I always say, for all the professionals, typically safety guys sitting here, it is very necessary to define the problem on hand very correctly. Do the right root cause analysis. I say this, right root cause analysis. Word तो बहुत अच्छा है, root cause analysis. But symptomatic नहीं होना है. Fact तक पहुँचना है, roots तक पहुँचना है और फिर decision लेना है. To just cite an example, I would come to the deployment of this entire learning at the last 5 minutes. So you might be thinking, topic क्या है, कहाँ बात कर रहे हैं, right? So during the World War II time, American planes which were coming back to the base, they saw lot many planes were lost during the war, and there were few planes which were coming back with gunshots on their wings and gunshots on their fuselage. So they started thinking, okay, these planes are coming back, they have got gunshots on their wings and fuselage. So they created a team of experts and they decided to put an additional armor to wings and to the fuselage. Now there was one mathematician who was also a part of that group. He came out with a different theory. He said, you are looking at the planes which are actually coming back. So that's a wrong way of analyzing it. You think of those planes which have actually got shot down. And those are the planes for which we have to look at, not the ones which have come back safely. Even if they have got shots on their wings, they have still come back. So this is not the problem. So defining the problem in the right way, they understood the planes which got hit on the cockpit or the fuel tanks, they were the planes which actually were lost, not the ones which got hit on the wings and the fuselage. So defining, then they understood that, okay, that's the problem which they were trying to identify is not the right way of tackling the problem. They might have taken a different course, but this is what is quoted in terms of defining the problem in a right manner. So for you also, I always say in the field of safety, we always, we have so many rules, regulations, laws, policies, whatnot and what available at our hand to ensure workplace health and safety of people. But this is all external. And what is internal with the person's brain is what actually will help him prevent or stay safe. So conscious, I think, okay. Let me ask to make people awake, people who are trying a bit more, who are feeling sleepy. Look at these two pictures. What do you see about that lady? What is her expression? What is her expression? She's angry, right? Everybody feels that she's angry? Anybody feels she is in a loving posture right now? No. Okay. What do you think of this gentleman? Who is he? Suited, booted, who is he? Does anybody know? Who is he? Nobody knows? What do you think? Based on his appearance? Okay, consultant criminal. He has got a new term, consultant criminal man. Okay. So I would like to start introducing you to a concept where everybody knows this, but I'm just trying to bring it back to you. How the brain functions. There is something which our brain judges immediately by looking at the picture or something, and there is something for which people have to do calculations. Some brain has to do some kind of arithmetic calculations. So the guy in the picture here in the black suit is actually a wanted criminal in Africa. He is not a businessman, he is not a consultant. Okay? So now, this is the mental system which I was talking about. Looking at the picture, you really know she is angry. But to do this calculation, you need to use the subconscious mind, put the formulas in place, and then you will get the answer. So this is not very easy. You will have to do it. Somebody who is very good at Vedic maths might do it very fast, but 99 out of 100 would not do it in this room. So coming to the main topic, our brain. Do you know brain consumes the most energy in our body? It is the most energy consuming organ of the body. Any idea how much energy the brain consumes? Yeah. Okay, I don't get into numbers at this point of time. There would be a debate. Whatever it is, whatever I have read also, it says 20-25% of the body's energy is consumed by the brain. Workout करने का जरूरत ही नहीं है. So when the brain consumes so much of energy, brain is also coded to conserve energy. So when I say this, it is called mental shortcuts. So if you do any activity today once, tomorrow twice, another thrice, 4, 5, the brain would subconsciously create a mental shortcut to do that activity. So what happens? Many times you might have felt this. ઓફિસ થી નીકળ્યા સાંજે અને ઘરે પહોંચી ગયા અને એની વચ્ચેનું તમને યાદ જ નથી. કેટલા લોકો સાથે? હાઉ મેની પીપલ હેવ એક્સપિરિયન્સ ધીસ? બોસ શું કરો છો? કઈ રીતે ડ્રાઈવ કરો છો? રાઈટ? યોર બોડી ઇઝ સો ટ્યુન્ડ, યોર બ્રેન ઇઝ સો વેલ ટ્યુન્ડ, તમને યાદ જ નથી તમે પહોંચી કઈ રીતે ઘરે. તમે કોઈ પૂછે રસ્તામાં આ જોયું? ના. મારી વાઈફે બી મને પરમ દિવસે પૂછ્યું પેલું પોસ્ટર લાગ્યું છે ટ્રાયથલોન ઇવેન્ટનું જોયું? કીધું ના એવું બધું હું જોતો જ નથી આમ તેમ. બાઘા મારવાના થોડી છે, આપણે તો રસ્તા પર જોવાનું છે. But this is how the brain works. Things which you do in a routine manner, your brain tends to create its own shortcuts. Okay, that is where we say they are all brains. આપણી મેમરીમાં આવી ગયું છે, સબકોન્શિયસ મેમરીમાં આપણે કહીએ છીએ, right? So this is where I say this principle has to be used to enhance safety at workplace. How? We will look into the application of this principle. But coming to the experiment that I was talking about, કેટલા લોકોએ ગુલાબ જાંબુ ખાધા? આઈસ્ક્રીમ ખાધું, ગુલાબ જાંબુ? How many? Everybody. આમાંથી કેટલા લોકોએ એના નીચે એક સ્ટીકર લગાડેલી હતી, એક લેબલ લગાડેલું હતું? How many people read that label? Okay, everybody read. તોય બધાએ ખાધા? Who is the one who read that he wanted to eat, he read this and then said, no, I don't want to eat now? Anybody? Oh, there is one guy. Akash? 4 बार खाया? नहीं खाया? अच्छा. Okay, so almost everybody knew एक गुलाब जामुन में 175 कैलोरी है, उसको जलाने के लिए ऑलमोस्ट 3.2 किलोमीटर, वो भी 20 मिनट में दौड़ना पड़ेगा. Still, and I bet none of you or very few would be able to run that, but still everybody had it. Thanks to the brain. 25% तो वो खा लेगा ना उसमें से, अपने को तो बाकी 75% का पड़ा है. So this was a very purposely done experiment to tell you, and why I did this particular exercise. See, information तो हमारे पास है. So you might have seen, अभी it is mandatory as per the FSSAI standards to declare the calorific value. But does that calorific value help? तो वो calorific value कोई फर्क नहीं पड़ता. 400 कैलोरी है, ठीक है, 4000 है, क्या फर्क पड़ता है? जब तक कि आप ये नहीं बताओगे कि वो 400 कैलोरी बर्न करने के लिए तुमको क्या करना पड़ेगा, something which makes sense to your brain, till that time that entire information is useless. So I have written 7 letters till date to the concerned departments to make such labels more intriguing or more effective in terms of making people really aware. अभी भी इतना easy नहीं है अपने आप पे वो, तो that process continues. Sorry. So these are some of the examples of routine exercises that we do. चाय बनाना consciously करते हैं, subconsciously? कितना लोग चाय बनाता है? चलो, how many people can make tea? Quite a few. Bias नहीं है. Driving kids to school or driving, taking, similarly, तीसरा example मेरा industry वाला है. To put the things into context, people also do their work in the industry subconsciously. Routine activity है, right? वर्क परमिट कब इशू किया जाता है? नॉन रूटीन एक्टिविटी के लिए इशू किया जाता है. सो एग्जैक्टली दैट मीन्स कि जो एक्टिविटी रूटीन कर रहा है उसमें तो उसको पता है सब कुछ ठीक है. जो वंस इन अ वाइल करने वाला है उसके लिए आपको बाकी का एडिशनल प्रिकॉशंस देखना है, राइट? सो सेम वे सबकॉन्शियसली जो चीज़ें हो रही है, कई बार जो एक्सीडेंट्स होते हैं, हाउ मच टाइम वी हैव? 5 minutes. ओके. सो आई थिंक ब्रेकडाउन मेंटेनेंस के लिए आपको परमिट्स चाहिए होता है, रूटीन एक्टिविटी के लिए परमिट्स नहीं चाहिए होता है. आई थिंक this is what is also a herd mentality we say. You would prefer this situation on the left or the one on the right? Everybody knows, right? लाइन में खड़े रहेंगे तो easily जा पाएंगे, सबका नंबर लगेगा, लेकिन तभी भी हम लोग ऐसे ही जाते हैं. I would skip because we have less time on this, but it's very difficult to cover this in 25 minutes, so sorry, but okay, I will come to this. Okay. Which is the color on the top and the bottom? Is it the same or it's a different color? Same color or different color? Everybody says same? Oh, तो फिर चलो. I would just take one example and I will come to the application of this concept. Otherwise, I would continue for next another hour or so. You know, in US, the healthcare costs, they have a huge problem of obesity. And the biggest sufferer because of obesity is insurance companies. You know why? Because the guys who are obese are actually a threat to the healthcare system, because they are the ones for whom there are huge claims. So the insurance companies started a process. They hired behavior scientists to find out how they can impact the entire, how they can tackle the entire obesity problem. And they found out the obesity is the root cause is the eating habits which are developed right at the childhood. So first I had asked Sujata ma'am to put sweets and desserts into a different corner, so that a person who wants to actually have it will have to travel a bit more to have that. Same way in US, they started putting perceived healthy foods at the eye level and perceived unhealthy foods at a slightly different level. So that for kids, it is such very simple thing. Plate ma jetlu pelli var bharaye etlu bhari le ane enathi pet bharayi jaye. So then there is no space available for eating the next lot. We are very different people. We are all very matured. Apanne to khabar che pachi dessert ખાવું છે તો જગ્યા રાખીશું. Kids are not like that. They will not eat a single bite extra after they are filled. So they are able, in US, they are able to tackle this problem in a better way today, while they are trying to inculcate this habit in the right at the children level. So આ છોકરાઓ મોટા થઈને obese નહીં થાય ત્યાર સુધીનો સાયકલ બહુ મોટો છે, but they have started seeing good results of this. This is another case study which I would talk about, or we can discuss offhand later on. But one more. How many of us actually follow all the traffic rules? We all know, right? Nobody here is not unaware that we need to follow this for our own safety, not for the sake of government. This is which I say warning labels, very effective. Is it? Is it helping? Think what else can be done. This is what I was talking about, the labels. We are talking of these kind of labels where it tells you this much calorie, this much walking or exercise is required. Has anybody seen this kind of an experiment? This is a male urine pot. So bias, females please excuse, but this is something which was done at Amsterdam airport. They put this small fly logo into the urine pot, and they were able to solve the housekeeping issues by 80%. Anyway, we have less time on hand. There are few things which I feel, can we nudge employees to be safe? When I say nudge, it means without telling them that you have to do the things in this way, can you make the conditions in such a way that they will behave the way you want them to do? This is the subject, and this is where I am still learning. I am not claiming that I have full expertise or a mastery on this. And it's, believe me, it's a very, very, I would say, interesting subject. And I would need anybody who is willing to collaborate, cooperate. I would seek their assistance into doing this, because it cannot be done by one person or even a group of people. So there are many activities. Things which we have started is permit systems which can be made more pictorial. There should be more picture rather than the language. Then you can have SOPs in the plants with people doing that activity with their own picture. So don't put only write-up. Write-up is boring, isn't it? Ketla bhi signboard lagao lakhela koi nahi vache. But if you put that particular plant person with his photograph doing that activity in form of an SOP, would he not take pride in doing that activity himself in the right way? Just 2 minutes more, sorry. There's another 5-star safety certified employee program. I say, see, in this world of instant gratification, रोज आपने Facebook पर post करता होइए छे, and all we like to see is likes and comments and all these things, right? So why not use this to appreciate your employees among the groups? people want only this thing. We are all knowing this, right? Twitter and Facebook crore rupiya kamai lidha chhe aani andarthi. Why not use it for our own purpose? Why not appreciate your own people? Create a internal competition to appreciate them, and this will help you to bring in the culture. And the last concept, which I say, safety buddy. There are people always who work in groups. Why not assign a buddy to each one of them and tell them, if you are my buddy, it is your responsibility to see to it that I go back home safely. If anything happens to me, you are the one who calls my wife or my mother and tells him that something has happened. Imagine a situation where you call my wife, and then what kind of language she would use, or you will not be able to face her, right? So you cannot have safety person always standing in the plant. To make it a line function, you will have to create such kind of systems where people take care of their safety on their own. I think I will stop here. That's about me. Thank you.
Thank you, Mr. Milind Ranade. I think after this session, everyone would think about safety not in the realms of legal and fiduciary purposes, but to explore the cognitive aspects of learning and unlearning. Thank you so much.
Thank you, sir, for the session. I request the chair to give a token of appreciation to Mr. Milind. I request the chair to call upon our next speaker. Thank you.
Good afternoon, everyone. After lunch, it is very, very difficult to listen all the topics, particularly within 1 hour. But now we have us, Dr. Neil Thakkar. Let me introduce him. He is a consultant pulmonary and critical care physician, affiliate to Stunning Hospital, Vadodara. He is a European diplomat in adult respiratory medicine and member of the ERS Assembly on respiratory infections and sleep-related breathing disorders. With 6 international publications as well as awards for best research from Indian Chest Society and American College of Chest Physicians, he has a keen interest in academics and evidence-based medicine. He is also an executive committee member in the Indian Society of Critical Care Medicine, Vadodara and Vadodara Chest Group. Dear friends, you know in the industry, one of the hazard and the target organ is chest, where the chemical are used, and one of the very, very major problem we are facing in occupational health in the industry is silicosis. So there are many problems related to target organ lungs. There are lung cancers and many other pathologies related to lungs. Now, Dr. Neil Thakkar will talk on occupational and lung disease, challenging cases and emergency. Here I invite Dr. Neil Thakkar, please.
Hello. Thank you so much for the kind introduction, sir. And so a very good afternoon to this august audience, to such an august gathering on a Saturday afternoon in a post-lunch session. It is a very difficult challenge for you itself to sit and listen here, but we are going to discuss regarding some challenging cases and emergencies. So the National Occupational Day went by last 20 days back around. The theme this year for occupational health is to create safer and healthier work environment. So I think Mr. Milind, the speaker just before me, discussed extensively regarding cognitive interventions which make health a safer environment. I'm going to discuss more towards a healthier environment in terms of what we can do, especially with regards to our lungs or for better breathing. Now, just as a show of hands, because this will have some technical medical information also, How many of you here are into the medical line as doctors, who practice as doctors? Just so that okay, thank you so much. So this is just so that during the session I will be as less technical as possible, and so that it can be a more interactive session. So what we will be discussing is regarding the basics, some basics of occupational lung disease, some interesting cases, how to identify an occupational lung problem, some specific modes of prevention, and how is sleep apnea. It's not an occupational lung disease, but it definitely can cause occupational hazards and accidents. So basically everyone who is a doctor would know, but for the rest of the people here, this is a basic lung structure. This in the center is a trachea, which divides into bronchi, which further divides into bronchioles. So these are our primary airways, and this is the final alveolus. So whenever we deal with any lung problem, why I had this as the initial slide is that whenever we have any lung problem, it is going to either affect the central airways here, or the smaller airways, or the interstitium which binds them together, which is known as interstitium. આ ત્રણમાંથી કોઈ બી જગા પર જ્યારે કંઈ પ્રોબ્લેમ થાય તો એ તમારા લંગ્સમાં પ્રોબ્લેમ કોઝ કરી શકે. Whenever we inhale any form of dust, fumes in the workplace, it can cause either a parenchymal, જે લંગ્સના છેલ્લા alveolus જે cells કહેવાય એમાં પ્રોબ્લેમ થાય, એરવેઝમાં પ્રોબ્લેમ થાય, કે પછી લંગ્સનું જે કવરિંગ હોય એને પ્લુરા કહેવાય. એ ત્રણમાંથી કોઈ જગાએ it can cause a problem. So when we inhale any sort of toxic substances at the workplace, it can cause a problem. Now for any environmental or an occupational trigger, when we label that this is an occupational lung disease, it has to be that the substance is in that environment, and it is been shown to be proven કે એના કારણે આ તકલીફ થાય છે, શ્વાસ વધે છે, ખાંસી વધે છે, કંઈક પેથોલોજિક, રેડિયોલોજિક અને પેથોલોજિક ચેન્જીસ થાય છે which are known to occur due to this, like cobalt exposure can cause interstitial and airway lung disease both. So this is a known entity. Second, that it can be multifactorial besides the occupation. Suppose there is an asthmatic who has an occupational problem also. So there are two factors here. The dose of exposure is normally an important determinant. કેટલા ડોઝમાં તમારા વર્ક એન્વાયરમેન્ટમાં એનું એક્સપોઝર તમને થયું છે. And individual susceptibilities definitely can be there. There is definitely most of the doctors here who are practicing in various industries do see patients periodically. Industrial workers જેમને કંઈ તકલીફ થતી હોય એમનું બેઝિક વર્કઅપ જે ચેસ્ટ એક્સરે છે, લંગ ફંક્શન ટેસ્ટ છે, એમના બેઝિક બ્લડ રિપોર્ટ છે, એનાથી they are able to pick up કે this patient likely has a occupational related problem, lung problem. So coming just to make things a bit more interesting, this is a case, 51-year-old male who was a plant operator in a thermal power plant. He's a non-smoker. He was symptomatic in the last 3 months with breathlessness on exertion, chest heaviness, some dry cough, weight loss, fatigue, and intermittent, as per the patient, low-grade fever. So now, because there was no documented fever, but this patient gave this history. Initially was given a trial of antibiotics, and after multiple trials, because patient remained symptomatic, he was prescribed by the local practitioner there કે ના તો આટલી દવાઓ આપી એનાથી ફરક નથી પડ્યો એટલે તમને કદાચ ટીબી હોવાની શક્યતા છે, અને એને ટીબીની દવા એમ્પેરિકલી ચાલુ કરી કે we will treat this because this looks to be, it is not improving, so it could be tuberculosis. Now this patient's chest x-ray is this. Now again, whenever we see any chest x-ray, like I showed you the initial figure, in the middle what we see, this is the heart shadow, this is the right lung, this is the left lung, this is the right diaphragm, this is the left diaphragm, this is the fundal gas, and this is the main airway, trachea dividing into two, right and left. So again, I won't go into too much technicalities, but this is something abnormal in the x-ray, which is a paratracheal right-sided shadow, which is there in the right upper lobe. So here this patient had this persistent shadow, and somewhat the heart shadow was slightly broader than normal, which we term as cardiomegaly, that this patient had some cardiomegaly and a right-sided paratracheal shadow. Patient underwent a CT scan, which showed that there was definitely a right-sided paratracheal density, which was present, and there is a lot of fluid around the heart. There is significant fluid collection around the heart. So this patient likely had a paratracheal mass with significant fluid collection around the heart. So this patient underwent an echo. This is the echo images where we can see that the right side, this is the right heart, and this is the left side, which is relatively compressed portion is on the right side. So the right heart chambers are getting compressed because of the fluid. And this patient, because the right heart chambers get compressed by the fluid, is having a cardiac tamponade associated with a significant amount of pericardial effusion. So patient underwent a pericardial aspiration. After that had significant symptomatic relief, and still the fluid reports were inconclusive. Blood reports showed a raised CRP. There was a secondary infection which was controlled. CT guided biopsy, because that lesion was right next to the main airway, was not possible. So patient underwent a bronchoscopy. Post bronchoscopy, again, because the lesion was right next to the airway, we were able to take a sample intraoperative right from that site and do a histopathological evaluation, which is done rapid on-site. In the procedure room only, we were able to take the biopsy sample and see what kind of a histopathologic problem there is. This is termed as rapid on-site evaluation, which is now available. With that, we were able to identify that, okay, this patient has a adenocarcinoma, that this patient, even though was labeled as a tuberculosis earlier on, later on was identified to have a malignancy and accordingly referred to an oncophysician. Advanced mutational studies were done and patient was started on definitive chemotherapy. Now, why am I discussing this case in an occupational health conference? Why? Because there is definite proof specific to thermal power plants which are coal-fired or other where the risk of lung and bladder cancer is very high in the work environment for the workers who work in that environment. This was a study which was published in the International Journal of Environmental Research and Public Health. Even though the data is from 95 to 2009, this was published in 2019, almost 10 years after that, that they were able to analyze the complete data retrospectively. They were able to find out that, okay, there is significant amount of exposure to benzene, nitrogen dioxide, particulate matter and sulfur dioxide, which is likely to cause lung and bladder cancer both. In this particular study, this was done in Italy, they were able to identify that the cancer was more common in the older age group females. Now again, we are not here to study the geography, but these are the clusters where in that region the gas exposure was very high with respect to the particulate matter, sulfur dioxide, benzene and nitrous dioxide. So again, what specific things in this study did they notice regarding lung cancer is that it causes air pollution in urban areas is a very significant risk factor. Smoking, occupational exposure and living near a pollutant source can be a risk factor for causing lung cancer. And thermal power plants, home heating and diesel engines. These are three risk factors which they were able to identify. Now again, these sort of studies are very much needed even in our setups, that in Gujarat or in wherever places you are practicing. With the data we have that, okay, this occupational worker, as in our case, turned out to have a malignancy. So if we have a registry, કે આટલા છેલ્લા 10 વર્ષમાં આ પાવર પ્લાન્ટમાંથી આટલા લોકોને આવી તકલીફ થઈ છે, તો we are in a position where we are able to identify, screen and prevent these sort of problems with taking appropriate precautions in our environment with respect to safety as well as to prevent this malignancy itself from occurring if we can take appropriate protective measures. Again, coming to an occupational history would normally include general health history, exposure, environment factors and past employment. How an occupational airway disease can occur is in the form of chronic bronchitis or industrial bronchitis due to the hyperreactivity of the airways. It can affect the nose or the throat in the laryngitis, rhinitis, the main airways, or even cause malignancy or interstitial lung disease. Now this is a very important table where with respect to your work profile, if you are in the coal mining or fire boiler industry, you will have exposure to arsenic and sulfur. In our case, this was a thermal power plant. The prominent pollutants will be chromium, elemental carbon, nickel. These are all likely to cause further problems to our lungs. There are short-term as well as long-term effects to various organs caused by particulate matter, sulfur dioxide and the other gases. So again, this is an important slide because based on what industry you are catering to, which sectors you are, These are the important pollutants which can cause short-term, long-term effects as well as likely long-term outcomes in terms of comorbidity in health. Coming to the second case, a 45-year-old male smoker. He is a farmer by occupation. He had an accidental ingestion of unknown substance. So again, there is accidental ingestion, but besides that, there is exposure also to this substance. Patient had multiple episodes of vomiting, breathing difficulty, and respiratory failure, came in with low oxygen levels. I would not go into the specific extreme details, but basic blood reports showed that the CRP was high. Patient had some renal dysfunction. Creatinine was also on the higher side. So we have a patient with some exposure to some substance which was ingested and also likely skin exposure to, had lung and kidney involvement both, and echo showed that the pulmonary artery pressure was high. So any specific substance, this is a farmer again. So again, what could be such a substance that is causing such problems such as lung and kidney involvement in a accidental ingestion and exposure? So again, this substance was paraquat. Paraquat is a toxic chemical which is a herbicide which is used, and most likely source of exposure is ingestion. However, it is possible with skin exposure also if unprotected skin surfaces come in contact with concentrated solutions of paraquat, and it is inhaled, it can cause extensive lung damage also. So patient was initially stabilized, airway, breathing, circulation was done, oxygen support was started at 2 to 4 liters. He was hydrated, a gastric lavage was done, patient had extensive vomiting also. Further, patient was admitted in the wards, given antibiotics, nebulizations, formoterol, budesonide and levosalbutamol, all three were given. Antacids and supportive treatment was given. Still, patient worsened over a period of 6 to 7 days. Further, still the inflammatory markers were increasing. Patient had severe respiratory failure, required non-invasive ventilation support. This was the patient's CT scan in that particular period of time. So in a CT scan, normally what we see is the main airways. What we see on both sides is the right and the left lung. Now what we are able to see is the extensive whitish discoloration in the black background. So extensively, this is extensive ground glassing with significant amount of septal thickening and destruction of the lungs. This is over a period of 10 days. Now, if this was not for the last 2 years, this scan would be relatively rare. Now, because we've been seeing such scans last 2 થી 3 વર્ષ, આ scan because of this pandemic, we have been seeing very frequently. But these are the patients who had developed exposure to paraquat and then extensive lung involvement after that, secondary to the exposure. Invasive ventilation was needed, gradually extubated. The blood cultures grew a bacteria which was methicillin resistant Staph aureus. Now because there is a bacterial growth, this patient eventually, because of the extensive lung involvement, was also started on steroids, dexamethasone, which was gradually tapered off. Now with the advent of technology and new research, we have other, even in the nebulization, we have other molecules where we can cause extensive good bronchodilation without using steroids, in the form of only long-acting beta-2 agonists such as formoterol or arformoterol, which can be used. And because there is extensive secretions, glycopyrronium nebulization was also added. Now what is arformoterol is a longer-acting beta-2 agonist where there is significant deflation in the lung, and over a period of time with use of appropriate nebulization, there is bronchodilation in these airways, and it leads to improvement in airflow and symptomatic relief. In terms of in chronic lung diseases as well as in other conditions, it can cause prolonged bronchodilation, decrease air trapping, and improve symptoms and the quality of life. What are compared to the other LABAs, there are fewer. Again, with inhaled steroids, a problem which we have is recurrent infections. If a patient is having, as in our case, had a bacterial pneumonia. So use of inhaled steroids in any form causes increased secondary bacterial infections. So again, to decrease the steroid burden in the lungs, we can use long-acting beta-2 agonists, which are potent for bronchodilation and reducing the overall morbidity related to the lungs. So again, before there are some specific indications where nebulization can also be used at home. Patients with a very less inspiratory flow rate, a poor hand-eye coordination with cognitive impairment, where there is a muscle weakness due to age or comorbidity, patients who are unwilling or find it difficult to use a pressurized metered dose inhaler or a dry powder inhaler, or who have a very poor breath holding capacity. These are the scenarios where nebulization may be a very good alternative. Coming further to our case, the patient gradually improved, the oxygen requirement went down, steroids were tapered to an oral dose of 20 milligram twice a day. Now again, as my previous speaker had mentioned regarding cognitive interventions, so even with respect to doctors, we find a lot of times patients are very much resistant to taking some therapies. So at that point of time, interventions where they agree to that therapy is very important, and besides drugs, maneuvers like chest physiotherapy, breathing exercises, other rehabilitation techniques are important in the long-term outcomes. Patient was started on, this was the scan after 3 weeks, after the initial scan, where gradually the fibrosis compared to the acute phase had decreased, but still extensive areas of fibrosis were there. Patient was discharged on long-term oxygen therapy and gradually improved. Now in our patient, these are the complications of paraquat exposure, heart failure, kidney failure and liver failure with lung fibrosis. This was a study which was published in a southern, from JIPMER in South India, published in the Indian Society of Critical Care Medicine in 2020. Mortality where a paraquat poisoning patient is admitted to a hospital is around 72%. And acute kidney injury is the most common manifestation. Pulmonary edema and acute tubular necrosis are other problems which occur. Case scenario 3, I will not go to this. This is just a scenario which, with respect to today's discussion we want to discuss, is a blast injury with inhalation injury, respiratory failure, ARDS and multiple organ dysfunction. I am not going into the specific case detail, but this is a case scenario which most of you at some point of time in your, you would face with a blast injury. So in such a case, what is important is the duration of the exposure. What is important is the patient's sensorium, oxygenation, his overall primary, whether he has any lung problem or not. We need to secure the airway, breathing and circulation, intubate as early and as clinically indicated, apply high flow oxygen. Again important, this is one of the few indications of oxygen where the patient's pulse oximetry is not important. If a patient has had carbon monoxide poisoning or exposure to carbon monoxide in the work environment, high flow oxygen is indicated in all patients. Patient should have, if there is loss of consciousness, severe metabolic acidosis, appropriate critical care setting, he should be aggressively managed. Now there is a bronchoscopic gradation for the abbreviated injury score for the inhalation injuries. Now any patient who presents with an inhalation injury, we can initially, when the time patient has just been intubated or at the primary presentation, we can see the level of inhalation injury via a guidance of a bronchoscope. That is a scope which is inserted into the main airway and goes into the lungs, and we can see the severity or the damage. There could be erythema, there could be carbonaceous deposits, or the mucosa could be very friable. This helps in depicting, if we have an initial assessment of airway injury, we can predict that how severe this patient, whether this is a study which was published in 2012, where they were able to show that at admission, if the patient's gradation is grade 3, then that is going to have a very poor outcome in terms of PF ratio, that is the oxygenation, the total PEEP requirement and the long-term outcome. So what they showed was grade 2 and grade 3 had severe ARDS at 24 and 72 hours, needed ventilator days, so more than 21 days, and towards the prognosis was towards mortality and MODS. So this you can help prognosticate a patient at day 1 if you have the assessment of the inhalational injury. Coming to screening options in lung disease, there is the chest X-ray, the lung function test or spirometry, the 6-minute walk test and the pulse oximetry. So just to make this session a bit more interactive, for the doctors who are here with us, what do you think? This patient has an occupational lung problem. What could this patient have? This is the patient's X-ray. If anybody would want to volunteer. This patient has he's been working in the industry. Whenever he goes to work, he has increased symptoms like cough, breathlessness and other problems. This is the patient's chest X-ray. Interstitial lung disease is there. Besides that, any specific, suppose I tell you this patient works in the coal industry. Coal. So this patient has a coal worker's pneumoconiosis with extensive, as we can see, different, okay, I'll have last 5 minutes I think, right? So again, this is how a coal worker's pneumoconiosis will look like. You will have nodular shadows. Based on the size and the coalescence of the shadow, we can grade the severity of the coal worker's pneumoconiosis. Accordingly, the management strategy has to be planned. This patient is working in an insulation industry. Anybody would like to see what this patient could have? He is in the insulation industry or say shipbreaking industry. So in that particular industry with this X-ray. So asbestosis is very common. This patient has a pleural plaque where we can see that the covering of the lung, which we are able to identify, there is a milkish hue in both the lungs. We can see a whitish discoloration which is layering over a black background that is characteristic of a pleural plaque. This patient, 3 manifestations. This patient is working in a stone breaking industry or a jeans sandblasting industry. Any specific? Silicosis is the right answer. So here, this patient could have silicosis can present initially with either a simple nodular appearance which is there in the above X-ray or progressively an axial calcification, or in this could be a progressive massive pulmonary fibrosis. PMF is the terminal presentation of a extensive exposure to silica. So spirometry is the investigation of choice for further assessment. I will not go into the detail, but what we see in a spirometry is the inspiratory loop, the expiratory loop, and post that if there is a problem with the lung volumes or lung capacity, we are able to identify what sort of a defect this patient has and treat it appropriately. In a spirometer, FVC, FEV1, FEV1 by FVC, these are the 3 values which most of the occupational doctors here would be seeing day in and day out. So you can determine the level of restriction, the level of obstruction, and the FEF 25 to 75. That determines the smaller airway problems which occupational exposures have predominantly. We see pre-bronchodilator, post-bronchodilator if there is any significant reversibility. Management which is common to all occupational lung diseases: you prevent exposure, you wear appropriate protective equipment in your work environment, you stop smoking, tell people around you to stop smoking, encourage an environment where you don't create a peer pressure for someone to smoke, immunize against influenza, pneumococcal and COVID vaccination. Steroids will help in acute exacerbations, lung rehabilitation including physiotherapy, adherence to the right therapy with the right technique. Again, an important aspect, latent TB infection should be treated with an occupational lung disease in the background. If a patient has a prolonged...
Dr. Neil, last 2 minutes, please.
Sure. So I'll be just finishing. So latent TB infection should be treated with a background of occupational lung disease. Any complication like airflow obstruction, respiratory failure should be timely treated. Sleep apnea, I'll just a word about it. It causes some level of upper airway closure, lower oxygen saturation. So if a patient comes to you or in your environment who has a significant daytime sleepiness, is seen dozing off at work, you don't continue asking that patient to work for a longer shifts or night shifts, because sleep disturbances are going to cause further problems. You need to diagnose sleep apnea at the right time. Sleep hygiene is very important. Sleep deprivation can cause many accidents. So again, what is most important, I'll be straight coming to that: sleep hygiene, regular bedtime, do not nap during the day, no alcohol, avoid coffees in noon, do not smoke before bedtime. Extensive screen time before sleeping is also not good for your sleep hygiene, and do not do mentally stimulating exercises or anything which causes too much mental stimulation 2 hours prior to sleep. So take home messages for this session: in any occupational emergency, time is health. The sooner you get earlier medical attention, it is better. Lesser but specific care is more important. Timely microscopic diagnosis is imperative, as we saw in our first case. Bronchoscopy important for non-resolving pneumonia, lung collapse with extensive mucus plugs, inhalational injuries where there is extensive airway injuries. Supportive critical care is critical to changing the outcomes for patients. Right drug, right candidate, and the right route is vital when you use home nebulization. Timely screening and lung rehab measures are important in any chronic and recurrent respiratory problem, and awareness regarding sleep apnea can prevent a lot of accidents. So this is my last slide. So this is something which I took at whenever we are thinking that we are in a lot of problems, at that time, probably like even in terms of health, that whenever we see that you face a lot of occupational health problems, when we think like interventions, cognitive interventions, medical interventions, these are supposed to help towards creating more future-ready organizations for health and safety, and this is the theme of the IOH this year. Thank you so much for your patient listening.
Thank you, Neil. You have completed in time. It was very good case study highlighted. I want to know, Dr. Neil, have you come across for any silicosis and any lung cancer, particular caused by particular chemicals? Have you come across such cases?
And eventually, again, we have an association that he's been working day in and day out there, and later on went on to have an adenocarcinoma. So that was likely related to there were no other, he was a non-smoker. There were no other specific risk factors which we were able to identify. His age was also around 40, 50 age. At that young age also he got that malignancy. Silicosis, again, Gujarat is one of the hubs, especially areas around Anand and Khambat. That is the area where we find a lot of cases in the stone breaking industry, where even silicosis and silicotuberculosis, where that's why I said latent TB infections are important, that we normally India માં 30% થી વધારે લોકોને latent TB તો હોય છે જ કે તમે મોન્ટુક્સ ટેસ્ટ કરાવશો, આટલા અહીંયા જેટલા લોકો છે એમાં બધાનું મોન્ટુક્સ કરાવીશું આપણે તો 20 થી 30%નું ટેસ્ટ એ પોઝિટિવ આવશે. કેમ? કારણ કે તમારા એન્વાયરમેન્ટમાં તમે એ વસ્તુનું એક્સપોઝર થયેલું હોય. પણ આપણે આવામાં બધાને ટ્રીટ નથી કરતા. But importantly, if you have an occupational lung problem, in such cases that is also important. But definitely silicosis, asbestosis, coal workers pneumoconiosis, and even we've seen extensive plaques which are secondary to asbestos exposure also, which cause a lot of restriction. And with the COVID pandemic, last 2 years we have so much overlap that so many patients જેમને occupational exposure, smoking, underlying lung disease and એના ઉપર 1, 2 કે 3 વાર COVID થયેલો હોય. તો હવે એમાં we need to then definitely streamline that what is the reversible portion and where we need to work towards a long-term rehabilitation plan. But definitely such cases are there in the occupational health industry which need timely attention. That is.
Thank you. With my co-chairperson, Dr. Samir, here we conclude this session, and we both are thankful to the organizing committee to give us opportunity to chair this session. Thank you so much.
Just a last vote of thanks to the entire organizing committee, Indian Association of Occupational Health, Dr. Kishore Parikh, Dr. Sameer Chaudhary, Dr. R.C. Saxena, Dr. Milan Thakur, and the entire people who created such a good event, planned, organized and initiated this entire event. Many, many congratulations to the entire team.
Thank you, Dr. Neil. I request the chair to give a token of appreciation to Dr. Neil Thakur. Thank you, sirs. We thank our chair, Dr. Kishore Parikh and Dr. Sameer Chaudhary for chairing the session. I call upon Dr. Sujata Rane, chairperson, scientific committee, GUJCON-2022, to give our token of appreciation to both of them. Thank you, Dr. Sujata. We have a slight change in our schedule. Since we had a late lunch, we'll be finishing off with the next session and then end today's day with high tea. So please, we'll be continuing today, right now. I call upon our chairpersons for the next session, Dr. Mitesh Shah and Dr. Amar Joshi on stage, please. Dr. Mitesh Shah is Occupational Health Advisor, Hitachi Energy Limited, and he is the Vice President, IOH Vadodara, with an extensive experience in ABB for 18 years. Welcome, sir. Dr. Amar Joshi is a consultant industrial physician with experience of 10 years in a wide variety of industries and has served as ICU physician for 6 years in Baroda Heart Institute and Research Center. Welcome, sir. I request the chairs to take up the session and call upon the speakers for the next sessions. Thank you.
Very good afternoon to all of you. I would like to introduce, and I am having privilege to introduce Dr. Rupesh Shah, who is our next speaker. Sir is very well-known surgeon in Baroda. Dr. Rupesh Shah is a chief surgeon of Sriji Hospital and Trauma Center, Chhani, Vadodara. He is a president of Association of Surgeons of Gujarat State Chapter since 2019. He is a EC member of Trauma Society of India. He is a EC member of Burns Forum India. And he is a core faculty for the skill enhancement program for the trauma at Sriji Hospital under the Association of Surgeons of India for junior surgeons. So it is my privilege to introduce him, and he is going to conduct the next session. Thank you so much, sir. Over to you, sir.
I am Dr. Rupesh Shah, practicing as a trauma surgeon at Chhani. You all know my today's topic is following trail of major accidents. See, following trail of major accident is a very vast subject. Many type of industrial injuries occur to various fine, so I could not move. Okay. So, my topic is very vast. Many type of injuries, many type of industries, many type of injuries. To explain of all is very vast subject. So, I will give you brief guideline how to manage such cases and what is a protocol to manage such injuries. But before that, I would have one disclaimer. Though I am explaining incidents of dipper nitrite industries which happened very recently, and I am a part of medical management team of that incidents, it would have occurred at any other industries. The things which I will explain would have been same. I will not expose name of any dignitaries or any officials or any patients for the sake of legality. Now, when call comes to you asking help for after major accident in a company, what is responsibility of a hospital head or a call receiver? We have to waste minimum time, get in maximum information, and give good assurance to that person. So I remember it would be early June, I think 2nd June, and it was evening time. I had just finished my dinner, and I had call from a very senior industrial physician of dipper nitrite, Rupesh, kya kar raha hai? I had said, bola sahab, shu thayu? He says, dipper mein bahut bada fire hua hai. I said, how it happens? He says, blast hua hai. मैंने बोला कितनी कैजुअलिटी होगा, कैसे कैसे क्या हुआ है? You just explain me in detail. He says बहुत बड़ा blast हुआ है and there will be multiple casualties. I assure him not to worry. everything will be okay. I am taking care of medical management. So I give him assurance, put the fall and rush to my hospital. My hospital is only 2 minutes away from my house. So sitting behind my car, I recollect it was Dipper Nitrite Company, burns and blast. So it would have been a burns injury, mechanical injury, and Dipper Nitrite is a chemical companies. So which chemicals, antidotes and all. So within a few seconds, I recollect or I made everything in my mind. And as a routine, we have a ready retina of antidote of all the companies where I am empaneled. And I have MSDS seat of all the companies. So before reaching to the hospital, what I had done, I had called to my emergency response team that consists of doctor, nursing in charge, HR personnel and admin. Intensives doctor has to inform all other faculty, all other doctors. He had informed our orthopedic surgeon, plastic surgeon, neurosurgeon, anesthetic team, chest physician, our medical officers, team of medical officers, and inform them about the situation and severity of the incidents. Our nursing in charge are supposed to inform in charge of our all department, our operation theater in charge, OT in charge, ICU in charge, ER in charge sister, our ward in charge sisters. Everybody has to inform by nursing in charge. Our admin has to inform housekeeping in charge, security head has to inform PRO person. They all were informed and asked X-ray technician, USG technician, lab technician, CT scan technician to get ready for the incidents. And it was a major calamity, as I was informed. We had informed our nearby hospital in case we may need them. So that also had to be informed. Our HR person's role is to manage manpower for all the department, all the specialties, nurses, doctor, housekeeping staff, security staff and all. Simultaneously, our ambulance person has to keep ready ambulance with all necessary equipment and all necessary staff. One ambulance immediately ran to Dipper Nitrite with all necessary equipment and support staff. And second ambulance was kept ready in our premises. My setup is a center of National Surgical Skin Enhancement Program governed by Association Surgeon of India, and my institute is a center for trauma skill training for junior surgeons. So we follow ATLS protocols, and ATLS protocol is very scientific, principle governed things to manage emergency cases, particularly in trauma. So it teaches us how to do organized team approach, what should be the priorities, what we say is triage and all, and what to prepare while we expect patient from the companies and all. So it is preparation prior we came across with the patient. So it is a teamwork in our hospital, in ER, emergency room. In emergency room preparation, it is a role of multiple faculties. Nursing staff has to prepare triage area. They have to keep ready or make sure to all proper air equipment, instrument function well. Laryngoscope, they have to check laryngoscope, multiple size of endotracheal tubes, ambush bag, good continuous and good level, continuous flow of oxygen, suction works well. They have to get ready IV crystalline solutions. They have to check about emergency medical stock, emergency medicine stock, and check trace card. Everything has to be ready. They have to find out or keep ready all different type of orthopedic splintages and dressing materials. And our emergency minor OT has to be kept ready for some minor dressing and immediate minor procedure. X-ray technician or X-ray machine, sonography machine, ventilator and defibrillator, which all we have in our emergency room. I am very glad to let you know I am having one of the biggest emergency reception room in Baroda, I think. We have 6 triage, 1 bed, which is very well equipped with all resuscitative facilities, multiparas, central suction, central oxygen. We have in-house, in emergency room, X-ray, sonography, ventilator and defibrillator. So that all has to be checked by a nursing staff and our HR person. Now, main important another factor, a person for emergency room is a doctor, team of a doctor. So we follow the things that one doctor or intensivist should always be a captain of the team, and under him, according to need of the condition, many doctors are deployed for the management. Our security team's personal person has responsibility to clear all emergency passages, keep ready stretchers, wheelchairs with oxygen ready, and manpower to handle that stretcher and wheelchairs. And main important thing for security personally is to control the entry into the emergency room. Other personally important in ER is HR, admin and reception. They have trained not to keep much time for basic information of a particular patient and all, but make sure they follow all legalities, medical legal aspect and all. Everything has been taken care of HR, admin and reception with the help of counter fellow of the companies. We follow triage area and all. We are having very big triage area. We cater in 6 bed in red zone, 4 bed in yellow zone and 4 bed in green zone. And this is the picture of my emergency room. Now second possibilities was burns. So how we prepare our burns area? We have dedicated burns area in our hospital. We have separate wash area, shower area to clean the patient. Many a times we get lots of chemical injuries or car burns on over the patient and all. So it is advisable to wash, and that made patient little cold also. Because of burns, it is advisable to have a shower to the patient. We have separate burn cubicles. We have 4 separate burn cubicles and 5 burn separate rooms. All rooms are equipped with a separate AHU, air handling unit, which is separate for our generalized hospital air handling units to minimize infection and to prevent cross infection. We follow barrier nursing system. So arrangement what that staff was make. We are using autoclave linen, autoclave dress to the patient, and of course we have to prepare autoclave dressing for a mass. So that was also a big job, and that was also made activated. As it was a major curiosity, we kept ready our OT also for dressing of a burns patient and informed plastic surgeon, intensivist and anesthesiologist. Same way, it could have been an inhalation burns. So our ICU was also kept ready for that. And our pulmonologist and intensivist was informed. We usually have policy to change room of burns patient every 7 days and autoclave in that room to prevent chronic infection. We do very dynamic burns treating criteria. We follow scientific approach and all. We do early biological dressing, and we do early transitional excision and early skin grafting. That saves time to get infection upon, reduce the days of the treatment, and that helps in psyche of the patient. This is few picture. This is patient 70% burns we had treated with biological dressing. This is a patient of around 65+%. We are treated with grafting at multiple limb and head and scalp also and face also. Another thing we had kept ready in ICU. We have 10-bedded ICU with 2-bedded step-down ICU and 2-bedded isolation room. Our isolation room was separately AHU. All beds were checked for all equipment necessary.
Sir, last 5 minutes.
See, actually, I think we are early today.
Yeah, no problem, sir.
Can I have liberty?
Yeah, sure, sir.
Thank you. So everything in ICU was kept ready. This is picture of my ICU. Our operation theater was also kept ready. Our OT in charge sister was asked to make few drums, burns dressing preparation and all staff was asked to be on toe whenever they called. We have modern NABH accredited ICU, 2 modular OTs, 1 septic OTs. All OTs are having all line, central line. We are not carrying any cylinders outside to the operation theater. Everything will be online, by pipeline. We have central oxygen, nitrous oxide, suction, air and CO2 supply. We have NABH recommended 3-zone CSSD for prevention of infection. And our OT has well equipped with latest technology and all. We had prepared rooms, and usually we see to it that all patients, if possible, and if we can arrange, we give them accommodation in same floor, so it will be better for all management. Not only medical management, but non-medical management also. We follow one person contact policy. Our doctors taught to companies' doctors. So it will be very easy to talk about patient management, condition of the patient, planning of the patient management, and what will be the prognosis or what will be the phase of the patient. So that company's doctor will be easily understandable, and he can make their higher authority to understand. So other thing, we together do counseling of the relatives. So relatives also have confidence because they often knows their company's doctors. And one most important thing, we combinedly inform certified surgeons to fulfill the legalities. Our HR person and company's HR person combinedly informing relatives, counseling relatives, they give information about injuries and what is the type of injuries, what could be the possible procedure we are going to do in detail, combinedly. And if possible, if condition permits, they allowed to talk with their relatives by video calling. And they combinedly manage for other associated requirement of patient according to condition of the patients. Our admin has to do all legal formalities. They have to see whether MLC has been done. He is a person to handle all police station formalities with local government officials. He helped to get related document to certified surgeons and all legal documents he helps. We follow patient first policy. So after settling the patient, his responsibility to do media briefing and local leaders briefing and all. While these incidents of dipert nitrite, I must say I had very good experience with all level, doctors level, HR level and admin level. We both worked harmoniously and I think we had given best possible result. Among them, I must mention, actually I had said I will not reveal the name, but I could not resist myself to mention the name, Dr. Jain, I think, who is here, very senior occupational physician. When he called me, I was feeling like his family member was having an incident. He was so dedicated and so caring. At all level, he was always asking, he was coming frequent time to the hospital, talking to me, talking to their head officials and all. And I cannot forget doctors who was all the time there for 24 hours. I think all the whole night he was there, and whenever I need any medical assistant, he was always there to explain relatives, to explain his company's officials and all. So I had very good experience, and I think dipert nitrate and I think companies, it is vice versa. So I had very good experience. Total 10 patient was admitted. 1 patient was treated in OPD base. It was twice. 3 patient was discharged after 2-3 hours. 9 patients were admitted after primary survey, secondary survey and all. 2 patients were discharged after 3 hours. They have minor elements. After few investigation, minor dressing, minor stitching, they were discharged. 3 patients were discharged after 24 hours. And 3 patients were discharged on 3rd day. 1 patient had major orthopedic problem and soft tissue problem, was discharged on 8th day after all surgeries. His follow-up is still on in Nadiad. He is from, basically he was from Nadiad. So with liaison of a surgeon and a hospital at Nadiad from my side, I am having continuous...
Sir, please conclude.
Okay.
Fine.
So, 5 minutes? 2 minutes, okay. So I am still on continuous follow-up of this patient. So, lesson learned, scientific approach, continuous learning, training, workshop, mock drilling and all, to keep ourselves updated is always helpful, and it is our problem and patient's problem. So, keep learning. And if I have liberty, I would like to show some cases. This is truss hand occurring in one industries which had vascular, nerves and large muscle injuries. We had treated with the team of vascular surgeon, neurosurgeon, plastic surgeon, orthopedic surgeon and all. We had done venous grafting, arterial grafting. We had done tendon transplantation. We had made tendon of bicep. And we could able to, with the help of, video is not working. Okay, with the help of physiotherapy and all, we could make this patient to drive his car. And he is always advised to come with your car driving to my hospital as a follow-up. These are few cases, soft tissue injury I am handling. All are industrial accidents. This is a case of head injury we had handled at our center. All are industrial accidents. This is a case of orthopedic injuries handled at my hospitals. Thank you. Thank you all.
Thank you very much, sir, for your presentation.
Thank you, sir, for the informative session. I request the chair to present a moment to Dr. Rakesh. Sir. Dr. Rupesh Shah. Thank you, sir.
Hello.
I request the chair to call upon the last speaker for the day. Thank you, sir.
So today we have reached to the last topic of the day, and for that I invite Dr. Chirag Seth from Rhythm Hospital. Dr. Chirag Bhai is a renowned cardiologist, a senior interventional cardiologist. He is a founder and director of this Rhythm Heart Institute, Baroda. Dr. Chirag Bhai is graduated and post-graduated. He done from MS University, and he has done his cardiology from Lucknow. I know him since last 15 years. He looks like as it is. Is very nice, gentle person. Gentle, is always mild and always cheerful personality. If a cardiac person goes to him, if by look only, he will treat the patient. Half of that his pain will go away. So thanks, Chirag Bhai, to come over here, and I will hand over to you. Thank you.
So good afternoon, everyone. Let me congratulate at the outset the Indian Association of Occupational Health, Vadodara branch, for organizing this meeting. And the theme of the meeting, like occupational health challenges and strategies, I believe my talk is going to highlight this aspect in the similar fashion as far as the cardiac problems are concerned. And my talk is likely to be more related to your facing situations in day in and day out in your practice. And to make it really little informal, I have tried to put up some case anecdotes, and it would be interesting to discuss with you and answer your questions if you have any. So going ahead with the talk, the aim of cardiac fitness for patients returning to work after having suffered a cardiovascular event, what should be the aim of our assessment? So aim should be to risk stratify the patients for future events. They have suffered one event, now we want to see what is the next likelihood of his events. Second, establish limits of safety at workplace. That safety is for himself also and for others also at workplace. Third is to promote physical and mental well-being at workplace within the constraints of ailments. Like a lot of them will be having limitations of their physical ability if they have suffered significant impairment of cardiovascular functions. And lastly, to promote lifestyle measures to reduce CV disorders. So this in a nutshell summarizes what our aim of managing these patients should be. When to perform this assessment? Ideally, this assessment would practically will fall into the first clinical follow-up at 7 to 10 days after discharge. And you need to review it again at 1 month, 3 months, 6 months, and 1 year. So who should be assessed, or what should be assessed? So quickly, I think these are the common things which we all of us know, and it can be done easily in our day-to-day OPD. First is body mass index, to make patients sensitize whether they are normal for his age and height. Do they have normal body weight? Are they overweight or underweight? Whatever it is. Control of risk factors for cardiovascular disease, that is diabetes, hypertension, smoking, and dyslipidemia. Third is to assess treatment compliance. Majority of patients at times, at some point of time, they will start thinking that whether these medicines are to be lifelong, it's a burden to us. And they are likely to miss those medicines. They are likely to think that it is a course, just like a course of malaria treatment or enteric fever treatment. And once they are fine, they are able to stop the treatment. So it is important to emphasize at every point that how important the compliance of the treatment is and why they should adhere to it religiously. Apart from this, what is important is to understand at first follow-up the current symptoms. And I would give a lot of emphasis on NYHA class. That means to find out how much comfortable they are as far as carrying out their daily routine activities well or not, right? So if they are able to carry out their daily routine activities normally, that means they are having functional class, at least NYHA class 2 or less. They are not badly symptomatic, like NYHA class 3 and 4. If we recall NYHA classification of cardiovascular disorder, I think people who are able to carry out day-to-day routine activities, if they are symptomatic, they are called NYHA class 2. So are they able to carry out this or not? That is the simplest question that we can ask, and that could risk stratify all those patients quickly, whether they are likely to be able to go back to work or not compared to other people. As far as blood pressure goes, look for postural hypotension, because when patients are in hospital, they are more often at bed, and they are on a lot of medicines to start with. At first follow-up, there is an opportunity to find out are they okay with these medicines or not. Many of them, once they suffer illness, they go into the strict discipline as far as diet and medicines are concerned. Many of them completely stop salt. Many of them reduce their water intake so much. Many of them go for strict dieting. Their blood pressure is likely to suffer. As far as our country is concerned, which has got a very hot and humid atmosphere, many of them present with postural hypotension. So that can be detrimental and it can affect their day-to-day working. Look for resting tachycardia. Again, it would be a sign of poor cardiovascular reserve and cardiac decompensation. And also look for subtle signs of depressive disorder and panic episodes. Like a young person, nowadays we see commonly a lot of people having heart disease in young age group, and when they are crippled with cardiovascular disorder, I think this is one increasingly important issue that you will be encountering in your OPDs that may have depressive symptoms. Many of them will feel uncertain about the future they are facing, uncertainty about financial aspects, uncertainty about risk to their own health, and worries about family. So I think subtle signs of depressive disorder and panic attacks, they also needs to be paid attention to, because that adds to their overall well-being. So what are the simpler tools with which we assess patient's fitness? First is ECG at rest. ECG at rest is important to understand that many patients having suffered cardiac disease may not have normal ECGs. So if we decide that if the ECG is normal, then only patient is fit to work, the list of people who can resume work will be minimized. So that shouldn't happen. We must understand that patients who suffer ST elevation MI, their ECGs are always going to carry some imprint as far as infarct goes. They will have Q waves, they will have some coving of ST segments, they will have T wave changes. Their ECGs may look broad, they may have left bundle or right bundle branch block, they may have excess deviations. So very few patients are likely to have normal ECGs. Majority of patients will have some abnormal ECG almost always, and our assessment should not restrict to only ECGs as far as the fitness goes, right? So ECG's rest is important to just compare with what his admission ECG or previous ECGs were, and is it worsening or it is remaining the same static without new changes. So this is important tool. At times when you take ECG at follow-up, patients ask you, has it become normal? So our answer should be, it is not expected to be normal. We are looking at, there is no worsening. So if you give them this kind of approach, this kind of answer, then probably they will be able to look forward to positive aspects of their recovery and not get caught up with the burden of the ailments. So ECG at rest is an important tool, but should not limit your fitness evaluation. Second is symptom-limited exercise testing. We'll come to it a little in the detail later on. Third is 2D echo for assessment of cardiac function of the cardiac event. And last is assessment of arrhythmic risk. I think one of the talk is going to be there tomorrow as far as arrhythmic risk is concerned, so I'll not go too much into detail. We'll just have a passing remarks about it. So we'll just go through some of the couple of cases. This will make us more practically oriented to this aspect in a better way. So let us see 24 years old male who is an aspirant doctor at Occupational Health Center. Is asymptomatic as such, does not have any clinical murmur or heart sounds. Routine ECG shows only deep T inversions of surface ECG. and echo shows a concentric LV hypertrophy, ejection fraction is normal. Now, should he join his duties or not? Right? I mean, these cases are actually, they have come to me, so I know, and that's why I have tried to put it up to evoke discussion and to understand. These are practical issues, right? An asymptomatic person with some ECG abnormalities and echo showing LVH, who has a normal blood pressure, ejection fraction is normal. Should he be joining the duty as far as occupational physician or not? Right? So there will be concerns about his health, and naturally, being a doctor, he himself also would be. So what should be the approach? So whenever you find LVH, asymptomatic person, deep T inversion, you are alarmed whether the patient has hypertrophic cardiomyopathy or not. Is the heart structurally normal or not? Is the person hypertensive or not? And therefore, take a detailed history. Does he have family history of sudden cardiac death in young? What is the extent of LV hypertrophy? Does it fit into hypertrophic cardiomyopathy? Many people with hypertrophy, they are labeled hypertrophic cardiomyopathy for the want of another diagnosis. We have to understand hypertrophic cardiomyopathy is not a diagnosis you can make casually. There is specific criteria as far as diagnosis is concerned, that you have to have septal and posterior wall dimension of the wall thickness in a particular way. It should be more, septal thickness should be disproportionately more than posterior wall. It should be more than 16 millimeter in diastole. So there are separate criteria for it, and it should not be a loose diagnosis that we can make it. So those criteria, whether they are met on echo or not, that should be looked into. Look for coarctation of aorta or aortic stenosis, aortic regurgitation. At times casual evaluation tends to miss the diagnosis of coarctation of aorta, so that can be leading to hypertension and ECG changes. Should look for Holter for arrhythmic burden, whether they have ectopics or not, especially ventricular, because what we are worried about is ventricular ectopics, VT, and ventricular fibrillation suddenly happening if there is substate of hypertrophic cardiomyopathy. Lastly, a patient should be advised a cardiac MRI to assess whether there is myocardial fibrosis. If you have myocardial fibrosis, significantly that adds to arrhythmic risk and a risk of sudden cardiac death. And finally, stress testing. If he is entirely asymptomatic, if all these things are negative, no family history, thickness is not great, more than 16 millimeter, no coarctation, structurally normal heart, Holter is okay, cardiac MRI does not show much fibrosis, ask him to go for treadmill test. If treadmill does not show any ectopics which are induced on exercise, right? And if he is able to carry out normal activities on treadmill, he is able to run, exercise capacity is good, there is no reason why he should not be fit to join duties. And if there is something abnormal, this list of tests would find out that there is something which should be paid attention to and accordingly can be managed. But the job of occupational physician, I think he should be perfectly fit as far as this profile is concerned. So simple ECG abnormality in absence of symptoms should not discourage us to give a fitness, and this person can be really fit to join the duty as occupational physician. Second, let us say a 44-year-old male, smoker and non-diabetic. Young patient, goes for acute ST elevation MI. It was in window period, thrombolized, ejection fraction is dropped to 35%. Angio shows recanalized LAD, so does not need a stent, but ejection fraction has gone down. Lipids are normal. And profession is a driver. He is driving a vehicle in one of the factories. So how to approach? Now he has symptoms of exertional dyspnea on walking for 10 minutes at a normal pace. So a person at 44 years of age is not expected to have this poor exercise tolerance, so it is compromised. Blood pressure and heart rate, they are fairly okay. ECG shows right bundle branch block, occasional PVCs. You can see a corrected QT interval is somewhat enlarged. And echo shows compromised ejection fraction. So what are the risks of this patient? Risks are risks of heart failure and reinfarction in first 3 months. A patient who suffered infarction is likely to have recurrent event in first 3 months. And second is the risk of sudden cardiac death due to low ejection fraction and PVCs on ECG. Now let us see if he is a driver. If he suffers this kind of event, which occurs unprovoked, without exertion, while he is driving, while at work, he is at risk of his own safety as well as others who are there in the vehicle along with him at risk. So this at times is not very much evident, but this is the kind of person who needs better risk stratification before he can join the duty and we can safely allow him to work, right? So this risk of sudden cardiac death is important as far as this person is concerned. So what should be done? Assess 24-hour Holter for burden of arrhythmias, whether he has ectopics there or not on ECG, whether he has silently arrhythmias occurring for a couple of seconds or couple of minutes. Optimize medical therapy for symptoms control, including diuretics, ACE inhibitor, if required, amiodarone, and beta blockers to reduce the risk of arrhythmia. Not to join work for at least 2 to 3 weeks, because risk of arrhythmic event is going to be high in first month. So don't allow him to join for on a first 2 to 3 weeks. Graded cardiac rehabilitation to build up exercise tolerance. At times when people have low ejection fraction, there is a tendency to restrict their activities. We would go a step further, that start with symptom limiting exercise, his mobilization till the extent that his symptoms are produced. So it should not be asked to completely remain bedridden, don't move out of home, remain completely at rest. No, that's not required. Ask them and promote that whichever symptoms they are able to tolerate, and if they are able to get mobilized, and they should be encouraged to do that, because we know that exercise training leads to peripheral vasodilatation, and it is supposed to be a tool as far as improving cardiac remodeling is concerned, and therefore symptom guided observation and gradual mobilization is to be permitted. Not to drive vehicle for at least 45 days. 45 days is the cutoff where arrhythmic risk, to some extent, early arrhythmic risk goes down. It does not completely become zero, not so that after 45 days the risk is not there. But if you see that infarct starts healing by that time, cardiac functions are stabilized, some amount of remodeling has set in, beyond 40 days probably the risk has remarkably gone down. Majority of early decline in events that has to happen, it would happen in first 45 days, and thereafter it would stabilize. And after 45 days, consider symptom limited exercise testing again on modified Bruce protocol, and if he's fine, he's able to achieve 5 minutes on treadmill without any arrhythmias or without any problems, then yes, he can restart and join the duty. A third person, let us say 56-year-old male, diabetic, hypertensive, unstable angina, triple vessel disease, good ejection fraction. CABG is done. He had only paroxysmal atrial fibrillation on day 2 of surgery, but is converted now to sinus rhythm. Discharged on day 10. He's an executive, professional-wise, he's an executive at a company. On day 10 of discharge, he comes with only fatigue, pain along surgical scars, some orthostatic hypotension, ECGs are okay, echo is normal, right? Only LV hypertrophy is present. Our concern would be paroxysmal atrial fibrillation. Like person who is young and he has a paroxysmal AF only on day 2. Now paroxysmal atrial fibrillation in perioperative phase is very common. In young patients without other risk factors, this does not mean that he is at high risk of developing time and again. So that should not be our major concern to limit his resumption to normal activities. If all other clinical parameters look okay, his fatigue and pain here and there is part and parcel of his post-op recovery and should not be a major issue as far as his resumption of work is concerned. And he should be fit to join if asymptomatic on routine activities at a later follow-up of 2 weeks or 3 weeks. And again, submaximal exercise testing, achieving more than 5 minutes. Case 4, 52-year-old female, febrile episode once prior to 5 days and sudden palpitation while at work, right? And ECG had shown a VT, ventricular tachycardia. Echo had shown a normal heart, electrolytes are normal, troponin and enzymes are normal, and MRI shows a non-specific myocarditis. Ejection fraction is good. Now, if a patient has a VT at one point of time, one would be reluctant to consider them fit to join duties, right? Now, there are good points as far as these patients are concerned, like echo is showing normal heart, good ejection fraction, MRI is also showing only non-specific myocarditis, and there are no other issues. She is, let us say, a profession-wise, a canteen staff with a moderate labor work. So in 10 doses of follow-up, she is on simpler drugs like metoprolol and amiodarone. She is asymptomatic on routine activities, no recurrence of arrhythmia, normal vitals, ECG is normal. What should you do for this patient? Again, myocarditis is a self-limiting condition. As far as the healing is concerned, many of the patients will become stabilization of that milieu which can lead to arrhythmias. And many of the patients will not have recurrence of events in future unless there is a lot of myocardial fibrosis. So again, same, assess at 2 to 3 weeks with submaximal exercise testing to decide fitness to work. And once that acute phase is passed on, once they are healed without any significant LV dysfunction, they should be able to resume the work after 2 to 3 weeks. Case 5, 36-year-old male, a project site manager in the fields. Fainting spell while at work. Very common, you will have it at workplace. Noted pulseless for 2-3 minutes and recovers completely with normal vitals. ECG and echo are normal, electrolytes and blood counts look normal. So clinically, this is likely to be a vasovagal syncope. If we go into the details, maybe it must be hot, humid atmosphere or a closed space, must be fasting or something, maybe dehydrated, and that's why he developed vasovagal fainting episode. And now he's completely recovered. So it's a common faint, in short, which happens very commonly in people with a structurally normal heart.
Sir,
and
last 5 minutes.
Sure, yeah, we are about to be at the end of the talk. So these are the people who are just they need assurance that they are fine, and if they take care of precipitating events, they will not have this kind of episode again, and they are otherwise fit to join duty even right from the next day. Case 6, last one, the 40-year-old obese smoker, unstable angina with triple vessel disease, troponin negative, echo is LV hypertrophy, normal ejection fraction, and he's undergone multi-vessel angioplasty. Factory worker by profession. When he can join the work? Earliest by 10 days. If there are no signs and symptoms of recurrent angina or heart failure, if vitals are normal and good ejection fraction or echo, they can join the duty even by 10 days. And again, for such kind of patients, one may consider submaximal exercise testing to reassure him that yes, you are fit to join duties. So stress testing is an important tool in deciding fitness to join duties. It is a simple, inexpensive, and reproducible. Like in the same patient, you do it at 1 month or 3 months, you'll be able to reproduce how much is the improvement. It can guide cardiac rehabilitation program. What you should be looking for is achievement of at least 80% of the target heart rate. Broadly speaking, 220 minus the age, that should be the target heart rate for any given person. And if the patient is able to achieve 80% of that, his cardiovascular fitness is reasonably good. Achievement of 5 minutes on exercise makes him fit to join duties, except a very heavy demanding physical labor. Majority of patients otherwise a moderate level of activity they will be able to do with if they have achieved 5 minutes on exercise. Heart rate and BP response. If patients develop excessively high heart rate, or if they develop vagal reaction during exercise, or if they develop exercise-induced fall in heart blood pressure, these are high-risk patients and they should not be allowed to join the duties. But otherwise, those who show proportionate increase in heart rate and blood pressure, they say that their cardiovascular reserve is good and should be allowed to work. And look for exercise-induced arrhythmias. Contraindication where you should not do. Untreated significant coronary ischemia, they should not be recommended stress testing. Symptoms with NYHA class more than 2 should not go for stress testing. Uncontrolled blood pressure, overt signs of heart failure, early post-MI if ejection fraction is very low, 30% and less. If you have fixed cardiac output state like aortic stenosis, mitral stenosis, dilated cardiomyopathy, if you have LVBB on surface ECG, if there are frequent ventricular ectopy on ECG, and lastly, patient's own refusal to walk. They may be reporting that I am fine, but at times subconsciously they know I won't be able to walk that fast. So if they decline, don't push them to go for a stress testing. Their own refusal to walk is important. So contraindication, these are the short list of contraindication to stress testing. And concluding this talk, what I want to convey is that try to understand the extent of cardiovascular reserve, which is likely to be compromised for every patient. Assess whether that cardiovascular status is compatible with his physical ability corresponding to his job profile. They may be okay in air-conditioned room, but their job may be in a outside zone where the temperatures may not be that controlled, so they may have decompensation. If they are working at remote places, at heights, then again their reserve may be compromised. So try to look for whether that status is compatible with their job profile or not. Majority with symptom class NYHA 2 or less, or NYHA class 2 or less, with LV ejection fraction 45% or more, they will be able to return to work within 2 to 3 weeks. And there is no need for prolonging their rest for 2 to 3 months. Submaximal exercise testing, 24-hour Holter, and 2D echo are important tools to decide fitness to resume work. And a structured cardiac rehabilitation programs are the need of the hour. And I think this is one thing which is lacking in the best of the institutions, best of the setups, best of the advanced economies, that a structured cardiac rehabilitation programs are not in place which can make the people join the work as early as possible with a scientific guidance. So I think when the theme of your meeting is that occupational challenges, what are the challenges and strategies, I think this one thing which you should be taking into account is how to put into practice, because increasingly younger people and younger workforce are going to have problems, and programs like this need to be there to see to it that you don't have attrition of manpower, and they should be creatively utilized in the workforce concern. Right? So with this, I would end the talk. Thank you for patient listening. Thank you.
Thank you, Chirag bhai. Thank you.
Thank you so much, sir. I request the chairs to present a memento to Dr. Chirag Sheth. Thank you, sirs. Okay, with this we end the session for today. I'll call upon Dr. Sujata Rane to present the memento to Dr. Mitesh Shah and Dr. Amar Joshi. Thank you, Dr. Sujata. I call upon Dr. Milan Thakur for the concluding remarks for today. Thank you. Sir.
Good evening, all. So I hope you all are happy with the academic sessions we had today. Yes or no? Okay. Hope બધાને મજા આવી હશે, બધાએ સારું સારું નોલેજ લીધું હશે અને આપણે બધા આજે ચા પીને 5 મિનિટ પછી છૂટા પડશું. કાલના એક સેશન્સ જે થોડા સારા છે તમને જસ્ટ 2 મિનિટ બ્રીફ કરી દઉં. કાલે આપણે ઇન્ડસ્ટ્રીયલ હાઇજીન એના ઉપર એક ડિસ્કશન છે, બર્ન્સ મેનેજમેન્ટ ઇન ઇન્ડસ્ટ્રીઝ, ઇન્ડસ્ટ્રીયલ કેમિકલ્સ એના એન્ટીડોટ્સ માટે ટોક્સિકોલોજીસ્ટનું સેશન છે. વડોદરા બ્રાન્ચ આઈઓએચનું એક ઓરેશન એવોર્ડ આપણે ડૉક્ટર રાજેશ સરને આપી રહ્યા છે કાલે. કેન્ટીન હેલ્થ અને હાઇજીનના સેશન છે એક એનું સ્પેશિયલ, જેની માટે ડૉક્ટર સંદીપ શર્મા સર દિલ્હી બ્રાન્ચથી આવ્યા છે સ્પેશિયલી. થીમ ડિસ્કશન છે, આપણી જે થીમ છે ઓક્યુપેશનલ હેલ્થ ચેલેન્જીસ એન્ડ સ્ટ્રેટેજીસ, એના ઉપર આપણા રિલાયન્સના ડૉક્ટરો, સિનિયર ડૉક્ટર્સ તમને ડિસ્કસ કરશે અને કેવી રીતે આપણે ચેલેન્જીસ જે આવે છે હેલ્થ સેફ્ટીમાં એને સુધારી શકીએ અને સારી કરી શકીએ એના ઉપર આપણે ડિસ્કસ કરશું. સો કાલે પણ આપણે સેફ્ટી, એચઆર અને હેલ્થ એવી રીતે પ્લાન કર્યા છે સારા સેશન્સ ફ્રોમ 9 to 5. અને આજે હવે જે સેશન બાકી છે એનું બ્રીફ કરી દઉં તમને. સાંજે 7 વાગે આપણે ઇનોગ્રલ સેરેમની રાખી છે ઓફિશિયલ ગુજકોન 2022ની. એમાં આપણા સ્પેશિયલ ઇન્વાઇટી ગેસ્ટમાં લેબર મિનિસ્ટર ગુજરાત શ્રી બ્રિજેશ કુમાર મેરજા સાહેબ આવવાના છે, PM શાહ સાહેબ ડિરેક્ટર ઇન્ડસ્ટ્રીયલ સેફ્ટી એન્ડ હેલ્થ એઝ અ ગેસ્ટ આવવાના છે, મેયર શ્રી વડોદરા કેયુર રોકડિયા આવવાના છે, ડૉક્ટર વિજય શાહ BJP પ્રેસિડેન્ટ વડોદરા, ડૉક્ટર હિતેન્દ્ર પટેલ સ્ટેન્ડિંગ કમિટી ચેરમેન વડોદરા. આ બધા મહાનુભાવોની ઉપસ્થિતિમાં આપણે સાંજે 7 વાગે ઉદ્ઘાટન સમારોહ કરશું. અને એ પતે પછી આપણે મ્યુઝિકલ ઇવનિંગનું આયોજન છે, જેમાં થોડું મ્યુઝિક, ડાન્સ અહીંયા પરફોર્મ કરશે અમુક આર્ટિસ્ટ, અને સાથે સાથે આપણે ગાલા ડિનર એન્જોય કરશું. સો વન્સ અગેન કે થોડી આપણને પ્રોબ્લેમ થયો સિટિંગ અરેન્જમેન્ટમાં, કારણ કે ડેલિગેટ્સ 40-50% જેવા વધી ગયા છે. અમે મેક્સિમમ ટ્રાય કર્યો કે તમને બધાને સારી રીતે એકોમોડેટ કરી શકીએ અને બધાને સેટિસ્ફાઈ કરી શકીએ. જાણ્યા અજાણ્યાથી અમારાથી કોઈ ભૂલ થઈ હોય તો અમે પહેલાંથી તમને સોરી કહીએ છીએ એની માટે. એન્ડ થેન્ક યુ ઓલ. યુ ઓલ હેવ યોર ટી એન્ડ વી મીટ એટ 7 PM. ઓકે, ગુડ બાય.